Hello guys, I'm Dr. Navneeth, your faculty of Pharmacology. Today, we are going with the rapid revision of Pharmacology. Now, I've designed this workbook in such a way that you'll be able to understand the basics as well as clear most of the questions that are asked in the exam. So, please try to follow this sequence as I've tried to keep the autonomic nervous system in the front because the understanding of autonomic nervous system is important for the FMGE exams. So, before starting this autonomic nervous system, I've also kept an introduction part where you get the basic concepts that are required for this entire pharma class. If you're very good in pharmacology, you can skip this, but I strongly suggest you that you go through this so that you'll have the flow of the class and you'll be able to understand much better. Yes, so let us start with the introduction. Now, in the introduction part, all of you know what is pharmacology. Pharmacology is study of drugs. And what do you study in pharmacology? You study the mechanism of action, their users, side effects, and contraindications. Now, how can you give these drugs into the body? Yes, there are two ways. One is systemic, the other one is local or topical. Local or topical. So, what is local way? Example, you're applying an ointment, that is local. The other one is systemic. Systemic means it should go into the systemic circulation. So if it has to go into the systemic circulation, there are two ways. One is enteral, the other one is parenteral. So what do you mean by enteral? Enteral meaning it goes into the gastrointestinal tract. Parenteral means it also goes into the systemic circulation, but it does not enter the gastrointestinal system. This is what I want you to understand. Now, in the enteral, how can you reach the GIT? There are two openings. One is oral, the other one is rectal. How about parenteral? How can you reach the systemic circulation directly without entering the GIT? Obviously, via injections. So, all of you know these injections. You must be very good at these. IM, IV, intradermal, subcutaneous, these are the types of injections that you give. Now, if you understood this much, what is the most common route of drug administration? Yes, it is oral. Obviously, oral is the most common route of drug administration. Now, let us try to see what will happen in the body when you give a drug orally. We'll try to start with an example. So, let us check your knowledge in medicine. Yes, let us suppose a person is having hypertension from very long, and he started developing these episodes of anxiety. In anxiety, what do you see? His heart rate is elevated. You tend to see palpitations and there are tremors in the patient because of skeletal muscle contraction. So, a person is having hypertension with anxiety. What is the best drug that you can give in this patient? Best drug as in drug of choice. So, what is the best drug for this patient? Obviously, it is propranolol. It is propranolol. So you try to give the propranolol, it is given orally. Yes. So we'll try to understand now. If we are giving propranolol in this person who is having hypertension with anxiety, what is going to happen? So let us see here. First, the drug goes into the mouth, then it goes into the pharynx, then it reaches esophagus. From the esophagus, it goes into the stomach and the small intestine. But most of the absorption happens in small intestine and stomach. Now, mostly in small intestine. Why? You must have studied in anatomy. Most of the food is absorbed through small intestine, especially in the duodenum. Why? Because of presence of microvilli. So, this is the same reason why the drugs are mostly absorbed in the duodenum, because of increased surface area. So, this drug is absorbed from the small intestine into the systemic circulation. What is happening? There is absorption. So we call this absorption. Obvious. Now let me ask you a simple question. If I want to increase the absorption of propranolol, what should I do? Should I make the drug lipid soluble or water soluble? Should I make the drug lipid soluble or water soluble? Simple question, only two options. What is the answer? Lipid or water soluble? Now, this is where most people get confused. Let us try to see this with the help of common sense. Yes, so you can see here, the drug has to cross the membrane of small intestine. Now, obviously, the small intestine is made up of cells, isn't it? So, this is the small intestine, it is made up of cells. I am saying the drug has to cross this cell, so it has to cross the cell membrane. Do you accept? All the cells are made up of cell membranes. Now, cell membranes are phospholipid bilayer, with proteins in it. So, if it has to cross the lipid layer, the drug should be soluble in lipid layer, yes or no? So, you want to make the drug lipid soluble, that's all. So, to increase the absorption, you want to make the drug lipid soluble, then the drug will be absorbed very well into the systemic circulation. Did you understand this much? So, once the drug is in the systemic circulation, what will happen? What is the function of systemic circulation? It will distribute blood to all the organs of the body. The same thing is going to happen. The systemic circulation will distribute this drug to all the organs in the body. Now, let us suppose to increase the absorption, I have made the drug lipid soluble. So, if this is a lipid soluble drug, first it will try to go into the organs or deposits in the organs which has more lipid content. Now, what is such an organ? Adipose tissue. So, yes, obviously it goes into adipose tissue and it goes into almost all the organs. Now, what are the important organs for us? That is what we are going to see now. So, let us suppose this is heart and let us suppose this is skeletal muscle. Now, the drug is going to all the organs, I accept. Now, the drug is also going into the heart. The drug will also go into the skeletal muscle. Yes. Now, on the heart, we have a receptor that is known as beta receptor. Again, on the skeletal muscle, we have a receptor that is beta receptor. Now, the most important concept that I want you to understand here, whatever effect you see in the body, it comes from the receptor. So, if you stimulate beta receptor, there will be increased heart rate. If you stimulate this beta receptor on the skeletal muscle, it will cause contractions. Yes, simple. Now, what I am saying is, when this drug propranolol comes here, this will block the beta receptors. So, if it blocks the beta receptor in the heart, it will decrease the heart rate. Now, if it blocks the beta receptor on the skeletal muscles, this will decrease the tremors. That's all. So, when you are decreasing the heart rate, it will decrease the blood pressure. It will also decrease the signs of anxiety. So, aren't you treating both anxiety and hypertension as well? Yes. So, that is why we are using propranolol. Now, which receptor are we blocking? We are blocking the beta receptor. That is why propranolol is also known as beta receptor. So, when are you getting the effect? The effect we are getting after the distribution. So, first there is absorption, then there is distribution. Now, after distribution, the drug is binding to the receptor and it causes effect. That's all. This is what has happened in the body. Now, think about it this way. Drug has caused the effect. Do you want the drug to stay on the receptor for a long period of time, or do you want the drug to come out of the body? Imagine. See, if the drug is staying on the receptor for a longer period of time, what will happen? Let us suppose in the heart, if it is blocking the beta receptors for a long period of time, heart rate will start decreasing. When it starts decreasing, if it is decreasing for a long period of time, the person might go into coma, the person might even die. So, this is causing toxicity. Do you want this toxicity to happen in the body? No. So, what should happen? The drug detaches from the receptor and it is excreted out from the body. Now, how do you excrete anything from the body, especially the main sources? Yes, you excrete things either through urine or feces. Now, what I am saying is, most of the drugs are excreted in urine through kidneys. So, it can be either from feces or urine, but mostly through kidneys in urine. That's all. So, let us suppose we have gotten the effect and now the drug is trying to excrete out of the body. Please don't write this down. Let us imagine if the drug is trying to be excreted from the body. Now, what is the functional unit of kidney? All of you must know this. Yes, functional unit of kidney is nephron. The nephron is made up of Bowman's capsule, and in the Bowman's capsule Before coming into the Bowman's capsule, what is the filtration unit that is made up of blood vessels, afferent and different arterioles? What is it? It is glomerulus. So the drug comes into the glomerulus and the drug is filtered. This is what is filtration. Once it comes into the proximal convoluted tubule, now let me tell you, most of the filtrate is reabsorbed in the proximal convoluted tubule. Yes, most of it. Now, will the drug be reabsorbed as well? Do you accept that the proximal convoluted tubule is also made up of cells? These cells will also have cell membranes. These cell membranes are also made up of phospholipid bilayer with proteins in it. Now, our drug is lipid soluble or water soluble? Try to imagine. I gave you the example. We tried to make the drug more lipid soluble for increasing the absorption. Now, the drug is lipid soluble. If it is lipid soluble, obviously it will cross this membrane and be reabsorbed back into the systemic circulation. It will be reabsorbed back into the systemic circulation. Now, the drug in the body will increase. Is it being excreted? No. So, if you want to excrete the drug, do you want the drug to be lipid soluble or water soluble? Simple question. It should not be lipid soluble, then it should be water soluble. Now this is the problem. I've given a lipid soluble drug. Now I'm saying I want a water soluble drug. How is this possible? How is this possible? Think. With the help of the liver, that is what liver does. Liver converts this lipid soluble drug into the water soluble drug. Liver converts what? Lipid soluble drug into the water soluble drug. This is what is metabolism. So what is the main aim of metabolism? It first converts the lipid soluble drug into water soluble drug. So the drug passes through the liver, it gets converted into water soluble drug and then comes into the kidney. When it is water soluble, this will be excreted through kidney in the urine. This is what has happened. So what has happened? First is absorption, second is distribution. Next we have gotten the effect. Once you got the effect, the drug is metabolized. Now after metabolism, the drug is excreted. So most of the drugs will be excreted through kidneys in urine. Yes. Now some of the drugs, while they get metabolized in the liver, they might be secreted into the bile. Now bile will obviously opening into the intestine, and from the intestine it will be excreted in the feces. Yes, but the most common way is urine. I've already told you. So this is what is happening in the body when you give a drug. What are the absorption, distribution, then you've gotten the effect, then there is metabolism, then there is excretion. This is what you mug it up. You call it ADME, absorption, distribution, metabolism and excretion. But this is the beautiful concept behind this. Now, if you understood this much, let us try to see what are pharmacokinetics. See, kinetics means movement. Now, will you accept there is movement in absorption, distribution, metabolism and excretion? You have to. Why? In absorption it is moving from the intestine into the systemic circulation. During distribution it is moving everywhere. In the metabolism it is going into the liver, and in the excretion it is moving out through the urine. So there is movement. That is why pharmacokinetics are ADME. Now, what is the definition for this? That is what we'll try to see. What is the definition? Is whatever body does to drug. Now, what is body doing to the drug? You can see here, obviously, body is absorbing the drug, body is distributing the drug, body is metabolizing the drug, body is excreting the drug. So, whatever body does to the drug, that is what is pharmacokinetics. Now, what are pharmacodynamics then? Dynamics, D for D, whatever drug does to the body. Whatever drug does to the body. What is drug doing to the body, you might ask me? See, the drug is binding to the receptor and this receptor is giving the effect. That is what is pharmacodynamics. That's all. You've gotten all the basics that are required for understanding the general pharmacology. Yes, you understood what are pharmacokinetics, what are pharmacodynamics. We just have to see the factors affecting them in general pharma and you're done with general pharmacology. Yes, if you understood this much, what did you understand in the body, which is the most important thing? Yes, obviously it is a receptor. Because only when you stimulate the receptor, you get the effect. Now, receptors are many types. We have inotropic receptors, we have cytoplasmic receptors, we have nuclear receptors, we have metabotropic receptors. In all of this, the most important one that I want you to understand for pharmacology is metabotropic receptor, that is also known as GPCR. GPCR means G protein coupled receptor. Now, I am not going to tell you in a lot of detail, but what I want you to understand is GPCRs are three types. They are GS, GQ, GI. Now, when you activate these receptors, what are the functions that these receptors have? We will try to see that. Now, it is easier to remember it this way. GS is stimulatory, so it is stimulating muscles. Now, how many types of muscles do you have in body? Three types. What are they? I've already given you the hint. There are three types. What are they? Skeletal, will you accept? Cardiac and smooth muscle. Now, when you are stimulating the muscle, what will happen? Contraction or relaxation? Obviously, it should be contraction. So, it causes skeletal muscle contraction. It causes cardiac muscle contraction. But this is what is most important. It will cause smooth muscle relaxation. It will cause smooth muscle relaxation. Please remember this one point. GS is stimulatory. It will stimulate everything except for smooth muscle. That is about GS. Yes, please get this into your head. Yes, this is about GS. Now, coming to GI. GI is inhibitory. So, it will inhibit. That means it will relax all the muscles. So, it is relaxing skeletal muscles. Yes, it is relaxing cardiac muscle. Now, smooth muscle relaxation has already been done by the GS. What is left? What is left out? That is GQ. Now, what is GQ doing? See, whatever is left out. Is smooth muscle relaxed? Yes. Is smooth muscle contracted? No. So, that is what GQ will do. GQ will cause smooth muscle contraction. That's all. So, what did I ask you to remember? Just one point. GS will stimulate everything except for smooth muscle. Now, remaining muscles are inhibited by GI. What is left out? Smooth muscle contraction. This will be done by GQ. So, when you accept this, when you activate this GQ receptor, what will it cause? It will cause smooth muscle contraction. This much you understood? Yes. Now, after studying this, I just want you to remember the two types of drugs that are most commonly used in practice. What are these? They are agonist and antagonist. Now, what will agonist do? Agonist will directly bind to the receptor. Directly. It will directly bind to the receptor and it will activate the receptor and increase its effect. So, what is agonist doing? It is activating the receptor. What is antagonist doing? It is blocking the receptor. It blocks the receptor. Did you understand? That's all. So, agonist will activate the receptor, antagonist will block the receptor. So, there are two classes of drugs I want you to remember for now. Now, these antagonists are also known as blockers. We've already seen one example of this beta blocker is propranolol. So, this is what I want you to understand from these basics. What are these basics? I've already told you pharmacokinetics are ADME. Pharmacodynamics are drug binding to receptor to cause effect. Now, when do you get the effect? After absorption or distribution? Obviously, after distribution. Then I told you about the receptors GS, GQ and GI. GS will stimulate everything except for smooth muscle. GI will relax the remaining muscles. GQ will contract the smooth muscle. Now, agonist is binding to the receptor and activating the receptor. Antagonist is blocking the receptor. That's all. So, if you understood this much, now, let us start with the autonomic nervous system. This is what is most important of in the exam, autonomic nervous system. Now, autonomic nervous system, is it a part of central nervous system, peripheral nervous system? We'll try to see it in a quick detail. Yes, central nervous system is, it is in the center. Brain and spinal cord are central nervous system, and whatever nerves are arising, those are peripheral nervous system. Which nerves are arising? Cranial nerves and spinal nerves. Did you understand? Two types. One is sensory, the other one is motor. Sensory nervous system will sense the information, motor nervous system will send the signals. Yes, now if these activities are under our control in the motor nervous system, if the activities are under our control, let us suppose I want to wave my hand, I can do it. This is happening with the help of somatic nervous system. So, this is voluntary. Now, if I ask you to increase the acid production in your stomach, If I ask you to contract the muscles of iris in your eyes, all of these are motor functions. Can you do it? No, you cannot, because these are involuntary. So in the motor nervous system, if it is voluntary, we call it somatic nervous system. If it is involuntary, we call it autonomic nervous system. So involuntary activities are controlled by autonomic nervous system. Given in the name autonomic, autonomous, it is doing it automatically. Yes, that's all. Now, if you understood this much, unfortunately, this autonomic nervous system is again divided into parasympathetic nervous system and sympathetic nervous system. Now, in this, you can study it in the anatomy, obviously, but the most important thing that I need right now for pharmacology are neurotransmitter and receptors. See, I told you all the effects come from the receptors. Now, on the receptor, what should act? In the body, we have something known as neurotransmitters. Neurotransmitter means it is sending signal from the nerves. It will act on the receptor and you will get the effect. Now, what is the neurotransmitter in parasympathetic nervous system? It is acetylcholine. What are the receptors? M and N. You must be knowing this. Quick revision for you: muscarinic receptors and nicotinic receptors. That's all. Now, coming to the sympathetic nervous system, what is the neurotransmitter here? Now, there are many. First, we'll try to see the main one. The main one is norepinephrine. What are the receptors? It is alpha, beta. For now, please try to understand this. Now, if you understood this much, you can see this nerve is arising from the brainstem. From the brainstem, if it is arising, this is cranial nerves. You already know parasympathetic nerves origin is craniosacral. In cranium, it is 3, 7, 9 and 10. It could be either 3, 7, 9 or 10 nerves. Let us suppose this is third nerve. So let us suppose it is sending the signal, oculomotor nerve is sending the signal. This signal will be transmitted here with the help of neurotransmitter. And this is ganglion. On the ganglion, there is a receptor present. And receptor will send the signal again and it is going into the organ. Oculomotor nerve is supplying which organ? Obviously in the eye. So eye has a receptor. Again, this neurotransmitter will work here. Now, what is the neurotransmitter? I have already told you it is acetylcholine, acetylcholine. What is the receptor on the eye? It should be muscarinic. So muscarinic and nicotinic receptors. Please try to understand this much. Now, one more important thing is nicotinic receptors are divided into two. NN, NM. NM means neuronal. It is present on neurons. M means muscles. It is present on muscles. Which muscles? On skeletal muscles. Now, skeletal muscles are voluntary. So, it is present in somatic nervous system. This is what I want you to understand. So, muscarinic receptors are anyways present in the parasympathetic nervous system. Now, NM receptors are present on somatic nervous system. Now, NN receptor, it is present on the neurons, and in between the neurons we have ganglions. So, anywhere we see ganglion, NN is present. You can see here the receptor is NN because it is present on the ganglion, obviously. Now, wherever you see muscarinic and nicotinic receptor, the neurotransmitter always has to be acetylcholine. This is what I want you to understand for now, okay? Now, about the neurotransmitters and receptors of sympathetic nervous system, we'll see all of this before starting the sympathetic nervous system chapter. For now, please try to remember this much. I told you acetylcholine, muscarinic and nicotinic. Nicotinic is again divided into NM and NN. NM is present on somatic nervous system. So, you can see this nerve here. In this nerve, does it have a ganglion? No, there is no ganglion. This nerve ends on the muscle. On the muscle, what is the receptor I told you? On the skeletal muscle, we have a receptor that is NM. So, this is supposed to be somatic nervous system. In somatic nervous system, also, the neurotransmitter is acetylcholine. So, this is what I want you to remember for now about the parasympathetic nervous system. Yes. Now, going to the functions of these systems. If you know the physiological functions of these nervous systems, you'll understand almost all the uses and side effects of the drugs. So, let us go through this in a quick detail. Yes? No. About eyes, parasympathetic nervous system. See here, what is parasympathetic nervous system doing? When is it used? It is a rest and digest system. Parasympathetic is a rest and digest system. That means it helps us in resting and digesting our food. So let us suppose when you're resting, what do you want to happen in the eyes when you're resting? Let us suppose you want to sleep. Yes. Do you want your pupils to become smaller, or do you want your pupils to become wider and look at everything? Obviously you want your pupils to become smaller. That is what is known as meiosis. So what is happening? There is meiosis in the eyes. Now coming to the salivary gland. So we are going from top to bottom. In the eyes there is meiosis. Now coming to the salivary gland, for digestion, do you want to increase saliva or decrease it? Obviously increase the saliva. So what is parasympathetic nervous system doing? It is increasing the secretions actually. Now even in the stomach, it will increase the gastric secretions, especially HCl. So it helps in the digestion. Yes. Now it will also help in the secretions of other glands also. So in the eyes you will also see lacrimation. Now coming to the bronchus, when you are resting, do you want to take in lot of air, lot of oxygen, or you want to take in some amount of oxygen that is enough for your body? Obviously some, no, or common sense. So if you want to take some amount of air, do you want the bronchus to become wider, bigger, or smaller? Yes, small bronchus is enough to take some amount of air. So there is bronchoconstriction. That's all. So you understood, it is causing secretions, increased secretions everywhere. Now it is also causing bronchoconstriction. Now if you want to digest the food, do you want the food to move from mouth into the esophagus, into the stomach, into the intestine? Yes, obviously for all of this has to happen, there should be peristalsis happening. So stomach should contract and intestine should contract, only then the food will move forward and it will be digested. So it will increase the contraction of stomach. It will also increase the contraction of intestines. If there is peristalsis, if there is movement, it will cause defecation. So all of these will lead to defecation. Same thing with bladder, it will increase the contraction. I told you it is increasing all the secretions and it is also increasing the urination. Next, about the heart. I told you it is increasing the secretions everywhere. Now, where is this parasympathetic doing the relaxation? Obviously, it is relaxing our heart. Now, this is blocking the SA node and it decreases our heart rate, because you know SA node is the pacemaker, and it blocks our AV node and it will decrease the conduction. That's all. So these are physiological functions, no need to mug it up, easy to understand. In the eyes there is meiosis, in the eyes there is lacrimation, and it will also cause accommodation. Accommodation is used to see whenever we are having objects nearby. You would have studied it in ophthalmology. Yes, so there is meiosis, lacrimation, accommodation. Next, coming to the salivary gland, it increases the salivation. Bronchus, you don't need a lot of air, so there is bronchoconstriction. In the stomach and intestine, to increase the peristalsis, there is contraction, and then there is also increased HCl secretion. Now coming to the bladder, increased contraction and it will cause urination. So defecation and urination. In the heart, finally it relaxes the heart and it decreases the heart rate and it also decreases the conduction. Now simple to understand, now when do you want to urinate and defecate? Obviously when you are resting. Yes, when you are stressed out, you don't want to defecate. Yes. So that is about the parasympathetic nervous system. Now if you want to understand in bit of detail, you will understand in sympathetic nervous system. Now you can see here what is happening. Sympathetic nervous system is a fight or flight system. Parasympathetic is rest and digest. Sympathetic is fight or flight. So you have to choose whether you have to fight or fly, or obviously you cannot fly, run away from the situation. So what is happening, we'll see. In the eyes, so when you're running away, do you want to look at everything? Yes, obviously you want to look far away, no, so that you don't fall somewhere. So do you want the pupils to increase in size or decrease in size? Obviously increase in size. This is what is mydriasis. This is what is mydriasis. Now coming to the salivary gland, when you're running, do you want to salivate all over? It doesn't look good, isn't it? So there is decreased salivation. What about bronchus? Do you want to take in a lot of air when you're running? Yes, you need a lot of air, you need a lot of oxygen, you want to increase your ATP. So there is bronchodilation. Now, what about the stomach? Let us suppose you're running somewhere, yes, and if you increase the contraction, it will cause defecation. Do you want to defecate and urinate when you're running away from the tiger? Obviously, no. So it will cause relaxation. It will cause relaxation of stomach and intestine. And in the bladder also it will cause relaxation. So there is urinary retention. If you understood this much, what about the heart? Obviously, when you're running, you want to increase your heart rate, isn't it? So that is what this is doing. It increases the heart rate. It increases the conduction. So that's all about the parasympathetic and sympathetic nervous system. If you see, sympathetic nervous system functions are exactly opposite to the parasympathetic nervous system. Simple to understand. When you're resting, what will happen? Meiosis, bronchoconstriction, salivation, defecation, urination, and then there is bradycardia. That means decreased heart rate. Exactly opposite in the sympathetic nervous system. People try to remember by this mnemonic. It is very famous. They call it dumbbells. I don't know the exact spelling. It varies, depends on situation. Dumbbells, they call it D for defecation. Yes, we have studied. U for urination. Yes, we have studied this. M for meiosis. Yes, B for bronchoconstriction. B for bradycardia. E for emesis. Emesis meaning whenever there is increased secretions, the secretions will come out of the mouth. That is emesis. Now, L for lacrimation. So in this there is only one L. L for lacrimation. S for salivation. These are the functions we have studied. Now you've gone through all of the basics, you'll understand why we have studied so much. So let us start with the drugs acting on the parasympathetic nervous system. Now, we have two kinds of drugs. One class of drugs will increase the functions of parasympathetic nervous system. That means it is almost working like parasympathetic nervous system. It is mimicking the parasympathetic nervous system. So we call it parasympathomimetics. Now the other class of drugs will decrease the functions. So we call them parasympatholytics. Lytics means lysis. So it is decreasing the function, so it is parasympatholytics. Now, if you remember, what is the neurotransmitter in the parasympathetic nervous system? It is acetylcholine. See here, acetylcholine is present both in ganglion and near the organ. So we can call it cholinergic nervous system. We can also call it cholinergic nervous system. So that is why these are also known as cholinergic drugs. And the parasympatholytics are also known as anti-cholinergic drugs. So we're going to study about two classes of drugs. They are cholinergic and anti-cholinergic drugs. I want you to understand this much. So in parasympathetic nervous system, we have cholinergics and anti-cholinergics. Now, what are the neurotransmitters? It is acetylcholine. What is the receptor? Muscarinic and nicotinic. Now, you understood the types of nicotinic receptors. What I want you to tell you is neurotransmitter acetylcholine, how is it formed? So, let us suppose this is one nerve terminal. Now, which nerve terminal am I taking right now? See here. Let us suppose I am taking this part. So, what are we seeing here? We are zooming in this part. So, this is the nerve terminal that I have taken it. I have turned it this way. So upwards I am seeing the nerve terminal, and here is the effector organ. So let us suppose this is the orientation of the diagram, this is the organ, and this is the nerve terminal. Now in the nerve terminal, let us see how is this acetylcholine formed. All the cells in the body will have acetyl coenzyme A. Will you accept? Yes, you have to. Why? Because glucose is converted to pyruvate, pyruvate is converted to acetyl coenzyme A in the link reaction. You must have studied this in biochemistry. So we already have acetyl coenzyme A inside, but what we don't have inside our cells is choline. So we take choline from outside, both of them will combine together to form acetylcholine. Now, whenever the signal comes, this acetylcholine is released into the synapse. That is why it is known as neurotransmitter. Now, if it has to be released whenever you want, it has to be stored in something. So, that storage area is known as vesicle. Inside the vesicle, acetylcholine is stored. Now, whenever signal comes in this nerve terminal, obviously signal comes in the form of action potential. This action potential will activate the calcium channels. So, the calcium will move inside. This calcium will act on the vesicle. This will cause contraction of vesicle. So, when there is contraction of vesicle, this vesicle will fuse to this synaptic membrane. You can see here, this is the vesicle that is fusing with the synaptic membrane. Otherwise, the nerve terminal is supposed to look this way, no? Now, why is it looking like this? Because vesicle is fusing with this and acetylcholine is released. Okay, good. Now, this acetylcholine will act on the receptors like muscarinic and nicotinic depending on the site. If this is muscle, this is supposed to be NM. Yes, if this is eye, it is supposed to be muscarinic receptor. So, the acetylcholine will act on the muscarinic receptor to produce its function. Now, what is the function of muscarinic receptor in the eye? I have already told you, parasympathetic nervous system in the eye causes meiosis. Now, acetylcholine, if it binds to the NM receptor, it will cause skeletal muscle contraction. So, did you understand this much? Neurotransmitter has to act on the receptor to produce the functions. So, this is how in the body the functions are generated by our nervous systems. Yes. Now, after its function, the acetylcholine will be metabolized. In fact, acetylcholine will act only for a very short period of time, even in milliseconds you can call it. When this acetylcholine acts on the receptor, it is detached from the receptor and this will be metabolized by acetylcholine esterase. Why are we calling it acetylcholine esterase? Because it breaks the ester bond present between acetylcholine. Now, when this is broken, it will form acetate plus choline. So, this is the same choline that is going up into our body. That is why we call it reuptake of choline. What do we call it? We call it reuptake of choline. So, we are recycling the choline. This is what is happening. Acetyl coenzyme A plus choline forms acetylcholine stored in the vesicle. Then it is released. It acts on the receptors. Then it is metabolized by acetylcholine esterase. And acetate plus choline is formed. Choline is reuptaken. This is the rate limiting step. Rate limiting step is the main important step. If you activate this step, the reactions will go very fast. If you block this, the reactions will be stopped. That is what is rate limiting step. You must have studied this in biochemistry. Now, why did I tell you so much of this? Why did I tell you so much of this? Let us try to see. Now, let us start with the drugs called cholinergic drugs. They are also known as parasympathomimetics. In these drugs, there are two classes. What are those two classes? First class is direct acting drug. The next class is indirect acting drug. Try to understand this mechanism. If you know this, you know almost entirety of pharma in this just one concept. Please try to understand. See, how are we getting the effect? Let us suppose in the eye, we'll talk about the eye. When muscarinic receptor is activated by acetylcholine, it causes meiosis. Now, if you want to cause meiosis by yourself, by giving a drug. So, let us suppose you are giving a drug from the outside and it acts directly on the receptor. It acts directly on the receptor and it will increase the function. If it is acting directly on the receptor, it is known as direct acting drug. That's all. It acts directly on receptor, so we call it direct acting drugs. So, if we give a drug that looks like acetylcholine, will it act on the receptor? Yes, it will. That is what is known as direct acting drug. If it is increasing the function, that is what is known as agonist. If it is decreasing the function, that is what is known as antagonist. That is what we have studied. So, we have finished the direct acting drugs. These are agonist and antagonist. Now, let us suppose if we don't have a drug that will look similar to acetylcholine, but you still want to increase the functions. How can you do this? Remember, understand. Yes, how can I do it? Let us suppose if I increase acetylcholine levels. I told you acetylcholine is working only for a milliseconds. Yes. Now, if I increase the levels of acetylcholine, can this act on the receptors for longer period of time? Can this increase the functions? Yes, it can. So, these are indirect acting drugs. What are we doing? We are not acting directly on receptor. We are acting indirectly on receptor By increasing the neurotransmitter. So we are acting on neurotransmitter. In cholinergic drugs, we are increasing the neurotransmitter. How can we do this? That is the mechanism of action. You try to understand. How is acetylcholine metabolized? It is metabolized by acetylcholine esterase. So if we give a drug and block this acetylcholine esterase, will acetylcholine be metabolized? No. The levels of acetylcholine will increase. It will act on the receptors. Then you get the effect. That is what are the classes of drugs. So these are the classes of drugs. What are they? Direct acting, indirect acting. Direct acting means acting directly on receptor. Indirect acting means they act on the neurotransmitter. Bas ho gaya. So these are the concepts I want you to be comfortable with in pharma. If you understood this much, rest all is going to be a cakewalk for you. Now, why am I telling you this? See, from now onwards, every single line that I tell you is very important for exam. It is either a PYQ or PYT from NEET or INICET or from AIMS exams or from FMGE exams. So these are all the PYTs and PYQs. So I am not going to repeat it again by saying this has been asked in FMG, this has been asked in NEET PG. Every single thing from now has been asked in exams. So I am going to cover the most important topics from now, and to understand those topics, you have covered and finished all the basics that are required. So let us see. We will start with cholinergic drugs. As I have told, cholinergic drugs means they act similar to parasympathetic nervous system, so they are also known as parasympathomimetics. There are two classes of drugs, direct acting, indirect acting. Direct acting means they act directly on receptors. Now, in direct acting drugs, we have two groups. First is alkaloids. Alkaloids means they come from the plants. Second is esters. Now, what are there in alkaloids? I want you to remember two drugs for the exam. First is pilocarpine, the second one is cevimeline. Please repeat it with me as many times as you can. Pilocarpine, cevimeline, pilocarpine, cevimeline. Very important. Pilocarpine, cevimeline. Now, let us try to see. Pilocarpine, I told you, it works similar to acetylcholine. That means it acts on the receptor and causes the function. So, what are the functions of these drugs? Obviously, what is the mechanism of action? In the eye, it can cause meiosis, yes or no? Yes, it can. If it is causing meiosis, this meiosis is actually helpful in some kind of glaucoma. If you remember, it is used in which kind of glaucoma? It is used in closed angle glaucoma. It is used in closed angle glaucoma. Please study this in ophthalmology. Whenever there is mydriasis, what is happening? Corneo-iridial angle is closed and it will cause, or it will precipitate closed angle glaucoma. So in this person, if you cause meiosis, it will be helpful in the treatment. So that is why it is drug of choice in closed angle glaucoma. So this is the use. So if you know the mechanism of action, you will get the use. You already studied this in functions. Did you understand this much? Now, what are the side effects? I told you, this will cause accommodation. Now, whenever there is accommodation, let us suppose this is the eye. Let us suppose this is the eye. Whenever there is accommodation, that means contraction of ciliary muscles, there will be pain, yes, around the eyebrow area, and it will cause headache or brow ache. So it is having headache. Next, it is also causing accommodation. Now, because of accommodation, whenever these muscles are pulled, it might pull this innermost layer. Now, what is the innermost layer? It is retina. So it might cause retinal detachment. Did you understand this much? Yes. So this is about the eye. Now, these will act similar to the parasympathetic nervous system. What is happening to the secretions? It increases the secretions in the eye. So it will cause lacrimation. It will also increase the secretion in the salivary gland. So it will cause salivation. So it is also increasing lacrimation and salivation. So these can be used in dry eyes and dry mouth. Don't you think? It can be used in dry eyes and dry mouth. Where do you see dry eyes and dry mouth? There is a syndrome in medicine that you must have studied where you see antibodies acting against these glands and destroying the glands and causing this keratoconjunctivitis sicca. That is Sjogren's syndrome. So in Sjogren's syndrome, pilocarpine can be used. Now we have made a new drug that is better than pilocarpine in Sjogren's syndrome. That is what is cevimeline. It is cevimeline. Did you understand this much? So pilocarpine, cevimeline. Pilocarpine is used in closed angle glaucoma. This is what I want you to remember. Now, if you are getting confused, easiest way to remember this, please see here, pilocarpine CA. So it is used in closed angle glaucoma. This is how I want you to remember it. Cevimeline is used in the Sjogren's syndrome. That's all. These are alkaloids. Now, coming to the second class of drugs, these are esters. We have finished with the alkaloids. Now we are coming to the esters. I told you ester bond is present between acetylcholine. So they are going to be similar. We have drugs called acetylcholine, methacholine, betanicol, yes, and carbachol. Now, in all of these, what is similar is the name choline. You can see the name chol in them. So whenever you see chol, it is a cholinergic drug. Easy way to remember. Now, two drugs are important for the exam. One is methacholine, the other one is betanicol. Methacholine is a short-acting drug. Betanicol is a long-acting drug. Long-acting drug. Now, short-acting drugs, are they used in the diagnosis or treatment? This is one more concept I want you to understand right now. In diagnosis, which one do you want to use? Yes. And in treatment, which one do you want to use? Easier one is with treatment. Let us suppose somebody is having hypertension. Do you want to give a drug that will act for 1 hour, or do you want to give a drug that will act for 12 hours or 24 hours? Think. If you give a short-acting drug, it will act for 1 hour. You have to keep on giving the drug again and again and again. So you would prefer long-acting drug in the treatment. Yes. So long-acting drugs are used in the treatment. Okay. Short-acting drugs can be given in emergencies, or better one to say is short and fast-acting. Yes, emergencies. Now, most importantly, it is also used in the diagnosis. Which diagnosis? See, methacholine is used in the diagnosis of bronchial asthma. This is also known as bronchial asthma challenge test. Why? Let us suppose a person is having bronchial asthma. He already has bronchoconstriction. If we give methacholine is a parasympathomimetic. What does parasympathetic nervous system do in the bronchus? It will cause bronchoconstriction. It will increase the bronchoconstriction and it will increase the severity of the symptoms. So now you know the patient has bronchial asthma. This is what is bronchial asthma challenge test. Did you understand this much? Now the problem is, if you give a long-acting drug in this patient, he will have bronchoconstriction for a longer period of time and he might die. So that is the reason why you give a short-acting drug for the diagnosis. Yes, so short-acting for diagnosis, long-acting for treatment. If you understood this much, let us see about betanicol. Now the thing with betanicol is it does not cross the blood-brain barrier. If it is not crossing the blood-brain barrier, it will act only in the peripheries. Yes, if it is acting in the peripheries, let us see, it will act on the organs that are present in the periphery. It will not act on the brain. Now, which organs are most important to us? Gastrointestinal tract and bladder. How to remember? B for B. Betanicol acts on the bladder. Now, in the bladder, what is betanicol doing? We'll see the mechanism of action. I told you, parasympathetic nervous system will contract the bladder. So, you can use this wherever there is no contraction of bladder. If there is no contraction of bladder, what do we call it? Atonic bladder. There is no tone in the bladder. Now, next is post-op urinary retention. What do you mean by post-op urinary retention? See, during the surgeries, we give anesthesia. Yes. Once you give anesthesia, it will take some time for the organs to recover. Let us suppose if the urinary bladder is not contracting, the urine will stay inside. That is what is known as post-op urinary retention. Now, you have to contract the urinary bladder. That is why we are giving betanicol. Same thing, if it is happening in the gastrointestinal tract, we call it post-op paralytic ileus. So, you have given anesthesia. Now, these muscles have not recovered. So, there is what? Constipation. The person is not able to defecate. So, if you give this betanicol, it will cause contraction of gastrointestinal tract. So, remember, B for B, betanicol can be used in bladder problems. That's all. We have finished the alkaloids and esters. Easy to remember. Alkaloids are pilocarpine, cevimeline. Pilocarpine CA, closed angle glaucoma. Cevimeline in the Sjogren's syndrome. Next, coming to methacholine, it is used in the diagnosis of bronchial asthma. Betanicol is used in the bladder problems. Where do you use it? In atonic bladder and post-op urinary retention or paralytic ileus. Thus, bus ho gaya. Yes. Now, we'll try to see the receptors. There is one question that has been asked in the NEET PG and we'll try to cover it as soon as possible. Yes. After this chapter, we will do the questions. I've added the question there. Yes, when we are solving the questions, you will see that. Now, if any of you have attended my classes before, I've told you a simple story to remember all the receptors. Now we don't have so much of time to tell you the entire story, but I'll give you the gist of it. Now, let us suppose you're going to classes for your FMGE or NEET PG coaching classes, whatever it is. Yes, when you're sitting in the class, obviously you're trying to listen, yes, and understand the concepts as much as possible. Now, all of you guys, let us suppose all of you are sitting in a class and suddenly a beautiful girl walks. I know what you'll do, but let us suppose there are two people. One person is mature, the other person is immature. Now, what will this mature person think? Yes, see, passing this exam is more important. So he'll think with his brain. He will think, exam pass karna hai. We have to pass the exam, earn money and fill our stomach. So a mature person will first think with his brain and will try to fill his stomach. If a person is immature, what he'll do, he'll listen to his heart. He'll go behind the girl. At the end of the day, the girl will not say, okay, he'll not pass the exam, he'll not fill his stomach. Did you understand? So immature people will listen to the heart. Easy to understand? Now, why did I tell you this story in a short way is, see, muscarinic receptor, mature receptor, M for M. So I try to remember it this way. Muscarinic receptor is a mature receptor. So first it will listen to the brain and fill its stomach. So M1 first, it is present in the brain and it is also present in the stomach. It will fill its stomach. How does the receptor fill the stomach? By increasing the HCl. That's all. Now, M1 receptor in the brain can also increase the cognition. We have done with M1 receptor. Now, mature person will first listen to the brain and he'll fill his stomach. Then he'll go behind the girl. So he'll listen to the heart next. So M1 is done, M2 is done. Now, what about M3? M3 is present in rest of the body. So everywhere else, M3 receptors are present. That's all. So what are the functions we studied in the parasympathetic nervous system starting with the eye? Do you remember? M3 is present in the eye. In the eye, what will it cause? It will cause meiosis. Then coming to the salivary gland, it will cause what? Salivation. Next, coming to the bronchus, it will cause what? Bronchoconstriction. Next, coming to the GIT, it will cause contraction. But increased HCl is by M1. Contraction is by M3. That's all. Next, last is bladder. It will also cause contraction. That's all. So you can see here, M3 is present in almost everywhere, all of the organs, and it is causing contraction of which muscles? Smooth muscles, skeletal or cardiac? Try to see. Eye. If there should be meiosis, there should be contraction of radial muscles of iris. These are smooth muscles. Now, if there is bronchoconstriction, contraction of smooth muscles, bronchus are smooth muscles. Yes, bronchi have smooth muscles, GIT have smooth muscles, bladder have smooth muscle. All of these are causing smooth muscle contraction. So smooth muscle contraction means it is GS, GQ or GI. That is why I told you the receptors are important. That is why I told you before. GS, GQ or GI, smooth muscle contraction. Everything is stimulated except smooth muscle by GS. But smooth muscle is contracted by GQ. Why did I write M3 and M1 together? Because both of them are GQ. That's all. So muscarinic receptors are GPCRs. M1 and M3 are GQ receptors. How do you remember this? With the help of common sense. I've already told you how to remember the receptors. Now you can understand the functions of the receptors from the functions table, and GPCRs. You can also decode this with the help of the table that I've given about the GPCR. So you don't have to mug up anything. You can understand each and everything. Yes, that's all. Now coming to the heart. What is happening in the parasympathetic nervous system? I told you it blocks SA node, it blocks AV node, so it will decrease heart rate, it will decrease conduction. So we are inhibiting SA node, we are inhibiting AV node, so this is a inhibitory receptor, this is GI. So that's all about the muscarinic receptors. You can see here, muscarinic receptor, how does it look? We have 1, 2, 3, 4, 5, 6, 7. So it is a heptahelical transmembrane receptor. This has been asked in the exam before. What is a heptahelical transmembrane receptor? It looks like a snake, so it is also known as serpentine. This is GPCR. You can see in the previous chapter also. These are GPCRs. Yes, how is it looking? 1, 2, 3, 4, 5, 6, 7. So this is heptahelical. It is passing through the membrane, so it is transmembrane. It looks like a snake, so it is what? Serpentine heptahelical transmembrane receptor. So example of GPCR is muscarinic receptor. We've already studied one of the receptors, M1, M2, M3, and then we also know about nicotinic receptors NN and NM. NM is present in the muscles, NN is present in neurons and ganglions. That's all. Now we have finished with the direct acting drugs. Now coming to the indirect acting drugs, you already know the mechanism of action. How are indirect acting drugs working? I've already told you. What is the mechanism of action here? It is acting indirectly on the receptor by acting on neurotransmitter. Since it is a cholinergic drug, it should increase the neurotransmitter or decrease it. Obviously, it should increase it. So, how can you increase the acetylcholine? By blocking what? Acetylcholine esterase. If you block acetylcholine esterase, acetylcholine will increase, and this will act on the receptors. You will get the functions. This is what is indirect acting drugs. Now, again in this we have two classes of drugs. One is irreversible, the other one is irreversible. What do you mean by irreversible? Irreversible means they will block the enzyme for a very long period of time. Let us suppose if we are blocking this enzyme for a very long period of time, acetylcholine will increase for a very long period of time. Now, this acetylcholine will cause excessive functions, increased functions of parasympathetic nervous system. So, it will increase the secretions. Yes, it will increase the secretions everywhere, and it will increase defecation, so it will cause diarrhea. It will increase the urination. Yes, it will increase the urination. Next, there will be meiosis, increased meiosis. It will cause pinpoint pupil. I think you must be correlating with this with some kind of poisoning that has been asked in exams so many times. Now, the most important thing is it is decreasing the heart rate a lot. So, the person is having some kind of poisoning. The person might die. So, we call it poisons. If we give irreversible blockers, they act as poisons. Did you understand? So, you can see here, irreversible indirect acting drugs are insecticides and pesticides. These are organophosphates and carbamates. That's all. So, that's all. These are the organophosphate and carbamate poisoning. What are the signs and symptoms of this? What are the signs and symptoms of this? You already know. Increased parasympathetic nervous system functions. What are they? Increased meiosis. So, it will cause pinpoint pupil. We'll write all of this. I have given a table. Increased meiosis, pinpoint pupil, increased lacrimation. Now, increased bronchoconstriction, defecation, urination. So, there is diarrhea, there is urination, then there is emesis, then there is bradycardia, all of these. That's all. So, these are the irreversibles. These are irreversible acting drugs. Now, in this you must have studied in the poisonings. Why is organophosphate and carbamate poisoning happening? I've already told you the mechanism of action, because it is blocking acetylcholine esterase. So, I've already told you organophosphates and carbamates will block this acetylcholine esterase. So, it will increase the acetylcholine levels. Now, why are we getting the functions? Because it acts on the muscarinic and nicotinic receptors. Yes. So, most of the functions that we know are because of muscarinic receptors. So, what are those functions? You already know. I've already told you the dumbbells, no? Yes, there is diarrhea, there is urination, then there is meiosis, bradycardia, all of these things you will see in organophosphate poisoning. So, the problem is because of activation of muscarinic receptors. So, what should be the treatment? We should block the muscarinic receptor. So, it is anti-muscarinic drug. So, what is the drug of choice? It is an anti-muscarinic drug. Please try to remember this one drug in anti-muscarinic drugs. This is very, very important. Has been asked in the exams so many times. Atropine. So, please remember this. Wherever you see a trop word, it is an anticholinergic drug or anti-muscarinic drug. So, in cholinergic poisoning like OP and carbamate, we give an anticholinergic drug. Simple. If there is cholinergic poisoning, we give anticholinergic drug. That's all. So, what is the drug of choice for OP and carbamate poisoning? It is atropine. Now, when you give atropine, all these symptoms will start decreasing. But what is the most common sign for this decreasing of symptoms? So when atropine decreases all of these symptoms, we call this as atropinization. How do you know the atropinization is done? What is the most common sign? Most common sign means the patient will have pinpoint pupil because of lot of meiosis. So if you open as eyelids and see, and if there is increased pupil size, then that means the organophosphate effect has been reduced. So most common sign is supposed to be mydriasis. But what is the most specific sign? Specific signs means this is the confirmatory sign that there has been atropinization. What is it? It is normalization of respiratory secretions. Now, it is difficult for some people to understand if the respiratory secretions are normalized or not. So that is why even though if it is the most specific sign, we still look for the mydriasis because it is easier to see. That is why most common is mydriasis, most specific is still normalization of respiratory or different thing is atropine will treat all the symptoms of organophosphate poisoning. True, except which symptoms? See, I told you acetylcholine will act both on muscarinic and nicotinic receptors. So whatever effects you are getting with muscarinic receptors, atropine will block it. Very nice. Now, what about nicotinic receptor? Nicotinic receptor is also present on the somatic nervous system. It is also present in the somatic nervous system. So, if it is present in the somatic nervous system, now increased acetylcholine acting on NM receptor, what will happen? First, there will be increase in contractions. True, they are also known as fasciculations. But if the NM receptor is stimulated for a long period of time, it will stop working and it will cause muscle weakness. It will cause muscle weakness. So, because of its action on NM receptor, there is muscle weakness. Now, atropine cannot block the NM receptor, so it cannot treat it. So, atropine will treat symptoms of organophosphate poisoning except muscle weakness. So, if you want to treat this muscle weakness, you have to give a drug that is known as PAM, that is also known as pralidoxime. So, you give oximes. So, that is the most specific drug for organophosphate poisoning, pralidoxime. So, all of these are exam questions, all of these, very, very important. Drug of choice for OP poisoning, carbonate poisoning, what is it? It is atropine. Most common sign for atropinization is mydriasis. Most specific sign, normalization of respiratory secretions. Next, it will treat all the symptoms except for muscle weakness. This has been asked in the previous recent FMGE exams. Yes. Now, what is the most specific drug for organophosphate poisoning is oximes, pralidoxime. But the important thing is oximes can be used only in OP poisoning. It is not used in carbamate poisoning. Now, how can you remember this? Please try to see here, organophosphates OP, pralidoxime OP. That's all. Done. So, most specific sign for organophosphate poisoning is pralidoxime. Now, if you understood this much, we have done with the irreversible. Now, coming to reversible. Reversible means it will block acetylcholine esterase for some period of time and then it will be normalized. So, it increases the acetylcholine for some period of time, okay, and it will give the function. So, it is acting like normal drug, so we can use it in treatment. So, irreversible drugs here are poisons. Reversible drugs can be used in treatment. Now, again in reversible, we have two classes of drugs. Try to remember this. One is tertiary amines. The other one is quaternary amines. What is important here? See, quaternary amines are water soluble. Problem with this? If they are water soluble, they cannot cross the blood-brain barrier. So they will act only in the periphery. How can you remember this? See, one of my students during the classes, he has given me a mnemonic. It is the easiest way to remember this. What is it? See, water. Where do you mix water? In the water. So quaternary amines are water soluble. This is what he has told me. Unfortunately, I have been using it. So quaternary amines are water soluble. Okay, so they will not cross blood-brain barrier. Tertiary amines are lipid soluble. They will cross blood-brain barrier. So they can be working in the diseases that are seen in the brain. Now, there is one disease where there is decreased cognition. There is an old person who keeps on forgetting things. Decreased cognition. What is it? It is dementia. Yes, dementia, Alzheimer's disease. In all of these patients, the cognition has decreased. Now, what did I tell you? M1 receptor is present in the brain, if you remember. See here, M1 receptor is present in the brain. It is increasing the cognition. So, if we increase the acetylcholine, it will act on M1 receptor. It will cause cognition. So, what are these drugs? These are tacrine, donepezil, rivastigmine, galantamine. Now, tacrine we are not using anymore because of hepatotoxicity. This question has been asked because of hepatotoxicity. Now, next question is, what is the drug of choice in Alzheimer's disease? It is donepezil. How to remember this? C, drug of choice, D for D, or easiest way to remember, Don is the most important person. So, donepezil is the most important Alzheimer's disease. It is the drug of choice. Okay. Now, in the INICET exam, they have asked, a person is not taking the oral drugs frequently. He is non-compliant. So, what will you do in this patient? If a patient is forgetting to take drugs, Alzheimer's disease means he doesn't have cognition, he has memory problems, so he is not able to take the drugs. If you give oral drugs, he might not be able to take it. What will you do? You can keep a transdermal patch. So the answer is transdermal patch. When the question was asked, rivastigmine was the only transdermal patch that is available during that time. So the answer is rivastigmine. Did you understand? So these are the three options that have been asked in the exam. Tacrine, hepatotoxic, donepezil, drug of choice, rivastigmine can be used as transdermal patch. That's all. These are about the tertiary amines. Now, one thing is left out, it is physostigmine. Please try to remember this, physostigmine, very important. I'll tell you in the end, physostigmine. Okay. Now, coming to quaternary amines. What did I tell you? Quaternary amines are water soluble, they do not cross blood-brain barrier, they will not act on the brain, they will act in the peripheries. Now, in the periphery, we have a disease. There is a disease that is causing muscle weakness. That is what is known as myasthenia gravis. Myasthenia gravis. What is myasthenia gravis doing? Let us suppose this is a skeletal muscle. On top of skeletal muscle, you have a receptor that is known as NM. When this NM is activated, you will have skeletal muscle contraction. In myasthenia gravis of antibodies, these antibodies will sit on the NM receptor. If antibodies are sitting on the NM receptor, will acetylcholine act on it? Obviously it cannot. Now, if it is not able to act on the receptors, what we can do? Let us suppose if we increase the acetylcholine, if we keep on increasing the acetylcholine, what will acetylcholine do? Acetylcholine will push this antibody outside and it will cause the skeletal muscle contraction. That's all. So, in myasthenia gravis, we have to give a drug that will increase the acetylcholine. So, which drugs increase the neurotransmitter? Indirect acting drugs. Okay. So, it should be reversible or irreversible. Okay. Do you want to give tertiary amines or quaternary amines? If you give tertiary amines, it will act on the brain. It will have side effects in the brain. So, you have to give quaternary amines. Did you understand this much? That's all. So, that is why in myasthenia gravis, we use quaternary amines. What are these? Edrophonium, neostigmine, pyridostigmine. Now, how to remember this? Edrophonium is a short-acting drug. Neostigmine, intermediate. Pyridostigmine, long-acting. This is the schema I am following here. So, short-acting is edrophonium, intermediate is neostigmine, long-acting is pyridostigmine. Now, I have already told you, short-acting means it can be used in diagnosis. Long-acting means it can be used in treatment. So, in treatment of myasthenia gravis, pyridostigmine. Diagnosis of myasthenia gravis, edrophonium. Now, the test that is used for diagnosis of myasthenia gravis using the edrophonium is also known as tensilon test. These are the most commonly asked questions in the exam. Tensilon test and the treatment of myasthenia gravis, it is pyridostigmine, edrophonium. Pyridostigmine, edrophonium. You have to remember this when you are studying anesthesia. In anesthesia, you will also study about neostigmine. Really important in anesthesia. It is used for the reversal of its NDMR reversal. You will study it there and you will understand it. NDMR means non-deep. Okay. So, how do I want you to remember it? Indirect acting drugs are irreversible, reversible. Reversible drugs are poisons. OP and carbamates, they are causing poisoning. So, use atropine. Next is what? Reversible. Irreversible, tertiary, quaternary. tertiary will cross the blood-brain barrier, so they can be used in the Alzheimer's disease. What are these drugs? Tacrine, donepezil, rivastigmine, galantamine. Now, what about the other class of drugs? These are quaternary, not soluble, not lipid soluble. So that is why they are not crossing the blood-brain barrier. It can be used in myasthenia gravis, edrophonium, neostigmine, pyridostigmine. Edrophonium is short-acting, so it can be used in the diagnosis. Pyridostigmine is used in the treatment of myasthenia gravis. That's all I want you to remember. Okay? So we have finished both the classes of drugs. So we have finished with the cholinergic drugs. These are direct acting and indirect acting. So one drug is left out, that is physostigmine. I do remember it. I will talk about it in the next chapter. Okay? And try to absorb all of this information inside. In direct acting, indirect acting. Direct acting में alkaloids and esters. Indirect acting में reversible and irreversible. Okay? And then we will start with the anticholinergic drugs. Now, you understood all of the parasympathomimetic drugs. Now we are going to the parasympatholytic drugs or anticholinergic drugs. Now I told you, everything is going to be really simple because you've already covered your concepts. What are those concepts? I told you the drugs can either be direct acting drugs or indirect acting drugs. Indirect acting drugs will act via neurotransmitters. Since these are anticholinergic drugs, they will decrease the neurotransmitter, so it will not act on the receptor and functions will be reduced. That's all. These are the mechanism of action of drugs of both direct and indirect acting drugs. You understood the mechanism of actions. Now, how many types of receptors do we know? We know muscarinic receptors and nicotinic receptors. So there are again two classes of drugs, muscarinic blockers and nicotinic blockers. Muscarinic blockers are known as anti-muscarinic drugs. That is what I told you to remember. One anti-muscarinic drug that is very important for the exam. What is it? It is atropine, is drug of choice for organophosphate and carbamate poisoning. Yes, this is about the muscarinic receptor blockers. These are also known as anti-muscarinic drugs. Now, nicotinic receptor blockers, again we have two classes of drugs. What are they? Because nicotinic receptors are divided into two, NN, NM. So we have NN blockers, NM blockers. NN is present in the ganglion, so we call them ganglion blockers. NM is present on the muscles. So if you block the NM receptors, it will cause muscle relaxation. So these are known as muscle relaxants. These are NDMR. These are curium drugs that you study in the anesthesia. Okay, so that's all about the nicotinic receptors. Ganglion blockers are not used commonly. NM blockers, you study it in the anesthesia. Now we have to concentrate on the muscarinic blockers for now. So in direct acting drugs, we'll study about muscarinic blockers. That is what is important for us now. So before we studied the classification based on alkaloids and esters, now we'll study it according to the organ. So first we'll go from the top to the bottom. Top we have CNS. Now in CNS we have two drugs that you have to remember for exam. Very, very, very important. First one is scopolamine. Scopolamine is drug of choice for something known as motion sickness. So whenever there is motion sickness, what is the drug of choice? It is scopolamine. Why? Because in the vestibular area we have M1 receptors, and if you block this, it will block this motion sickness. Yes, what is motion sickness? When somebody is traveling in a car, they will feel nausea, vomiting. No, this is because of the movements that happen. This is motion sickness, and the drug of choice for this is scopolamine. Next is benzhexol or benztropine. Benzhexol is also known as benztropine. I already told you, wherever you see the word trop, if you see trop, what is it? It is an anti-muscarinic drug. I told you it is an anticholinergic drug. So benztropine. Benztropine is drug of choice for drug-induced Parkinsonism. This I will teach you in detail in central nervous system. For now, remember it is drug of choice in drug-induced Parkinsonism. That's all. In the brain there are two drugs, scopolamine and benzhexol. These questions have been asked so many times in the exam, I cannot even count it, so many times. Be NEET PG, INISET, FMGE, doesn't matter. Scopolamine, benztropine will be asked, has been asked. Most important, yes, scopolamine, benzhexol. Scopolamine, it is used in motion sickness. Benzhexol, it is for drug-induced Parkinsonism and drug-induced EPS. extrapyramidal symptoms, you use benztropine. Okay. Next, coming to the eyes. Now, in the eyes, what will happen? This is what is important to us. Now, in the eyes, what will happen? I told you M3 receptor is present in the eyes. It is causing meiosis and accommodation. If you block this, what will it cause? Mydriasis. So the eyes are becoming bigger. I mean, not the eyes, the pupil size is becoming bigger, and it is easier for us to examine the eyes. So you can do fundoscopic examination. Yes. Now, it is also causing cycloplegia. That means paralysis of accommodation muscles. So it can be used in refractive error testing. So if you know the mechanism of action, you will know the uses. I've already told you. So in fundoscopic examination and refractive error testing, what are the drops that you generally use? You must have gone to ophthalmologist. They must have kept drops in your eyes. What are the drops they are keeping? It is tropicamide. So tropicamide is the drop here. So what are these? Tropicamide, cyclopentolate, hometropine and atropine. Atropine is usually used in children and it is used in the ointment form. Why you study in opthal? Atropine eye drops are contraindicated in children. That is why we give it in the form of ointment. Why? Atropine can be absorbed through nasolacrimal duct, and atropine, when it goes into the systemic circulation, it can cause atropine poisoning. We'll talk about atropine poisoning in a while. Okay. Now, if you understood the eyes, what about secretions? Now, anticholinergic drugs, obviously opposite effect. Parasympathetic nervous system is increasing the secretions. So these drugs will decrease the secretions like lacrimation, salivation and all of this. So they can be used as pre-anesthetic medication. Why? If the secretions are decreased, it will decrease the risk of aspirational pneumonia. It will decrease of aspiration pneumonia. That is why they are used in pre-anesthesia. Okay, what is the drug? It is glycopyrrolate. Now, in all of these drugs, if I tell you to remember some drugs, it has to be scopolamine and benzhexol. Okay, glycopyrrolate is a pre-anesthetic medication. You'll study this again in anesthesia. Tropicamide used commonly. Atropine ointment is used in the children. Yes. Now, going to the lungs. Important. See, if you activate the parasympathetic nervous system, remember methacholine, what will it do? It will cause bronchoconstriction. Now you are blocking the M3 receptor, so it will cause what? If you block the M3 receptor in the bronchus, it will cause bronchodilation. So these drugs can be used in obstructive airway disorders. Especially these are used in a COPD. It can be used in bronchial asthma as well, but it works better in COPD, so we use it in COPD. Yes. What are these drugs? We have three classes of drugs. What are they known as? SAMA, IMA and LAMA. These are not some fancy woman names, okay? SAMA means short-acting muscarinic antagonist. IMA means intermediate-acting muscarinic antagonist. LAMA means long-acting muscarinic antagonist. Everything is given in the name. So, IPRA is SAMA, Oxy is IMA, Thio is LAMA. This is what I want you to remember. It is given in the name. Tropium, all of these are anti-muscarinic drugs. So, IPRA, Oxy, Thio, SAMA, IMA, LAMA. That's all. Now, coming to the heart. Very important. Which receptor is present in the heart? M2. M2 is what? GI. So, GI receptor is actually blocking SC node and AV node. So, it is causing what? Bradycardia and conduction block. Okay. Now, if I give atropine, this will block M2. This will block M2. If it blocks M2, it is blocking the blocker. So, the blocking effect on SC node and AV node are lost, and it will cause tachycardia and conduction. So, it can be used in bradycardia. Do you accept? Why? Because it is causing tachycardia. It can be used in conduction block. Do you accept? Yes. Why? Because it is increasing the conduction, and I've already told you two things before. It is also drug of choice in OP poisoning, carbamate poisoning, and one important question from forensic, it is also useful in early mushroom poisoning. Early mushroom poisoning. In fact, this is the drug of choice there. Why? If they eat these mushrooms, it releases something known as muscarine. Muscarine acts exactly like acetylcholine, and it will have the exact symptoms like organophosphate poisoning. So, what is the drug of choice? Atropine. So, 5 things you have to remember about the atropine. First 3 are pretty important. What are they? It is drug of choice in bradycardia, OP poisoning, carbamide poisoning. Next are conduction block, and the next one is early mushroom poisoning. I want you to remember all of this about atropine. Atropine, very, very, very important drugs. If I tell you 3 important drugs in these chapters, they are first atropine, next scopolamine, next benzhexol or benztropine. I want you to remember all these 3 drugs. Okay. Now we have finished the heart. Now we are going into the GIT. Now in GIT we have 2 receptors. We have M1. We have one is increasing HCl. So if you block M1, it will decrease HCl. So it can be used in peptic ulcer disease because it is decreasing HCl. It can be used in peptic ulcer disease. What is this M1 blocker that can be used in peptic ulcer disease? It is pyranzapine and tilanzapine. Have you ever heard these names or seen these tablets? No. Why? Because in peptic ulcer disease we usually take PPIs. These are the drug of choice. But one NSAID exam they have asked what is the M1 blocker that is used in peptic ulcer disease. At least try to remember P for peptic ulcer disease. You use pyranzapine. Now if you block M3 receptor, M3 is causing the contraction. So if you are blocking the M3 receptor, it is decreasing the contraction. So it is decreasing the contraction means it is relieving the spasm. So that is why we call it antispasmodics. Now what are the drugs? You've already studied this. One is hyoscine. Hyoscine is also known as scopolamine. We've already studied this. Scopolamine is drug of choice in motion sickness. Next, if you finished scopolamine, next one is glycopyrrolate. Glycopyrrolate is also used for pre-anesthetic medication. The other one is dicyclomine. Only other drug you have to remember. Yes, this is commonly used as well. If you know, yes, women when they get menstrual pains, they use a tablet called meftal-spas. It contains mefenamic acid along with this dicyclomine. Okay, that's all. Coming to bladder, this is the hot topic that has been tested in NEET PG and NESET frequently. So it might be asked in FMGE, but it is very important for NEET PG and NESET going people. So you guys keep on asking if this rapid revision can be used for FMGE or NEET PG or NESET. See, whatever the exam, the concepts are going to be the same. Yes. So there might be some additions here and there that you have to make, but the core concepts are going to be same for NEET PG, FMGE, NESET, doesn't matter. Okay. So talking about the bladder. Now bladder, what is the receptor we have? M3 receptor. Now we have some classes of drugs that are used in the bladder problems. Now first let me tell you where are these anti-muscarinic drugs used in the bladder problem. Now let us go to the beginning. Parasympathetic nervous system is causing contraction of bladder, so you can use it in atonic bladder. Okay, but muscarinic antagonist means it will relax bladder. So mechanism of action is relax. If it relaxes bladder, we can use it in areas where the contraction of bladder is more or activity of bladder is more. That is what we call it as overactive bladder, or we also call it urge incontinence. What happens in urge incontinence or overactive bladder? Bladder is active. That means it is overactive. It is contracting. So in this patient, you will give relaxants. Did you understand? So use is overactive bladder. Okay. Now what are the drugs? Please try to remember: oxybutynin, flavoxylate, fesoterodin, trospium, solifenacin, darifenacin. I know you might feel little intimidated by these things, but I'll give you a mnemonic, easier way to remember this. But please follow the same scheme, okay, same flow. Why? You'll understand in a bit. Yes, please try to remember this. I told you overactive bladder means there is overstimulation of bladder. So how can you treat this? You decrease the stimulation. No, that means you switch off the stimulation. So the treatment is of the stimulated bladder. Those are the drugs. Bas ho gaya. See, O, oxybutynin, F, flavoxylate, F, fesoterodin, of T, trospium, of the stimulated solifenacin. Bladder, you can see here, bladder, Darfur, darifenacin. That's all. Of the stimulated bladder. You can ask me, sir, why do I have to remember in this same scheme? I will tell you. Why this order especially, I'll tell you. See, oxybutynin is a very powerful acting drug. So it works well in overactive bladder. If a person is having overactive bladder, if you want to pick an antimuscarinic drug, which one will you pick? Oxybutynin, perfect, well done. Exam. Now, let me give you a case. Okay. See, oxybutynin is a powerful acting drug, okay, but it acts on all the receptors. It also blocks M3 receptor, it also blocks M3 receptor in other organs, not just bladder, in the other organs. It also blocks M1 receptor in other organs. Example, brain. If M1 receptor is blocked, it will cause a side effect, dementia. Now you tell me, which people have overactive bladder, young people or old people? Obviously old people, no. Old people are usually blessed with many problems. They also seem to have dementia. If a person is having dementia and overactive bladder, which antimuscarinic drug will you give? Will you give oxybutynin? Tell me, will you give oxybutynin? You should not. Why? It is acting on M1 receptor and it is increasing the dementia. This is the question that has been asked in the exam. So they have given options like oxybutynin, flavoxylate, fesoterodin, solifenacin. What will you pick? Now, let me give you the concept. If you go in this way of the stimulated bladder, so the last two drugs are M3 specific drugs. That means they block M3 receptor mainly on bladder. So mostly they are only blocking the M3 receptor that is present on the bladder and treating the overactive disease. Or okay. Now, does that mean it only acts on M3? No, it acts mainly on M3. That means there is some action on M1 also. Very, very little. So it has some dementia. But if you ask me which is better, oxybutynin, flavoxylate, fesoterodin or solifenacin or dorifenacin, obviously answer is solifenacin or darifenacin. Did you understand this much? This is one question. Now I am changing the options. Listen to me carefully. Same options, instead of fesoterodin I am keeping trospium. Oxybutynin, flavoxylate, trospium and solifenacin. Which one will you pick? See, even though solifenacin and darifenacin are M3 specific in bladder, trospium, please try to remember, it is a quaternary amine. What do you mean by quaternary amine? Quaternary amine is water soluble. If it is water soluble, will it cross the blood-brain barrier? See, even though it can act on M1 receptor, it might act on the M1 receptor that is present in the stomach, true. But can it cross the blood-brain barrier and act on the M1 receptor present in the brain and cause dementia? No. That is why this is the best drug for overactive bladder in dementia. Did you understand? Please write this. Overactive bladder with dementia. If they ask, which antimuscarinic drug can be used? Which antimuscarinic drug can be used? Obviously, the first preference should be trospium. Okay. If not, or darifenacin. That is what I want you to remember. That is why I gave you that mnemonic of the stimulated bladder: oxybutynin, flavoxylate, fesoterodin, trospium, solifenacin and darifenacin. Did you understand this much? Once you go from oxybutynin to solifenacin and darifenacin, they will become M3 specific block. But why are we using trospium? Because it is quaternary amine. That is why this is very important for your NEET PG and NESET exam questions. Now, if I ask you what is the drug of choice in overactive bladder with dementia, it is none of these drugs. Which one is the drug of choice? That we will study in the sympathetic nervous system. If you know it, please comment. Okay. Now, after finishing the muscarinic antagonist, so we have done with all the muscarinic antagonist. I already told you about the nicotinic antagonist, that means nicotinic blockers. Now what are we left with? Indirect acting drugs. Now what are these indirect acting drugs doing? I already told you, indirect acting drugs means it has to act on the neurotransmitter. It should decrease the neurotransmitter. Now how can you decrease the neurotransmitter? You can decrease the synthesis. What is the synthesis? Acetylcholine coenzyme A plus. Acetylcoenzyme A plus, choline forms acetylcholine. Acetylcholine will be released. So how can you block this? See, acetylcholine it will be converted to acetate plus choline, that I already told you, and then there is choline reuptake. So you can either block this. How can you block this? With the help of hemicholinum. Not been asked in the exam, hemicholinum, but easy to remember. Hemicholinum means it looks like choline, so body thinks it is choline and takes hemicholinum inside of choline, and it does not form acetylcholine, so it is decreasing the neurotransmitter. But what is very is botulinum toxin. Botulinum toxin. What will botulinum toxin do? Botulinum toxin will directly block this release of acetylcholine. It will block the release of acetylcholine. That is what botulinum is doing. This question has been asked from microbiology and pharmacology so many times. So botulinum toxin is blocking the release of acetylcholine. Let us suppose if it is blocking the release of acetylcholine, can it act on the NM receptor present on the skeletal muscles? No. Then it will relax the muscles. Let us suppose if you are frowning too much, you will have wrinkles here because the muscles are contracted. Now, by giving the botulinum toxin, you are relaxing this and the wrinkles are gone. That is why Botox is nothing but botulinum toxin is used for the wrinkles. Did you understand? Very important. Please study this. Botulinum. Next is hemicholinum. The other one is Ves. Everything is given in the name. See, hemicholinum looks like choline. Okay. Vesamicol. It stops the choline from entering into the vesicle. Again given in the name. Why? Vesamicol. Vesicle में choline को आने नहीं देता है. That's all. Vesamicol, hemicholinum and botulinum. Botulinum is the most important exam going topic that you need to remember. That's all. We have finished all the anticholinergic drugs. Now, what is important for us? I already told you about the cholinergic poisoning. Okay. What is happening in cholinergic poisoning? I told you. I'll write it here. Yes. See, in the eyes. What is happening? There is increased meiosis. So there is pinpoint pupil. And then there is increased lacrimation. And it will increase all the secretions. It will also increase the salivation. Why? We'll understand this in the sympathetic nervous system. It will cause bronchoconstriction. In the stomach, it will increase contraction. In the GIT, increased contraction. So what will happen? It will cause diarrhea, and in the bladder it will increase contraction. So it will cause urinary incontinence. That means there is a lot of urination. Sweat glands, it will increase the sweating. See, salivation we've already talked about it. I'm talking about the sweating. Sweating thing you'll understand in the sympathetic nervous system why there is sweating. Now, about the heart, muscle, it will cause muscle weakness. What is the drug of choice in all of this? Atropine. So drug of choice for OP poisoning, carbamate poisoning or cholinergic poisoning. Cholinergic poisoning is happening because of OP and carbamate. Let us suppose you are giving atropine. See, atropine is usually given in the 2 mg injections. So you have to keep on repeating until there is atropinization. Unfortunately, if you give too much of atropine, other than atropinization, there will be the side effects. It will cause toxicity. So that is what is known as anticholinergic poisoning. So anticholinergic poisoning can happen because of atropine. How? There, if you give too much of atropine or accidental ingestion of atropine. See, atropine comes from Atropa belladonna. It also comes from Datura. So if a person eats flowers and fruits of Datura, Atropa belladonna, or takes so many injections of atropine, it can cause anticholinergic poisoning. So what will be seen in anticholinergic poisoning? Exactly opposite to the cholinergic poisoning. Here the patient will have mydriasis, decreased lacrimation, decreased salivation. So if there is decreased lacrimation, there will be dry eyes, decreased salivation, dry mouth, bronchodilation. Next, it will cause relaxation of what? Stomach and GIT. So it will cause constipation. What about the urine? Again, relaxation of bladder. So there will be urinary retention. Now, what about the heart? It will cause tachycardia. Now, what about the brain? In the brain, it will cause delirium. So that is when you understand, when you give atropine in a higher dose, it will cause delirium and it will cause all these symptoms. How do you treat it? This is the important question. See, this is anticholinergic poisoning, okay? So in cholinergic poisoning, you are giving anticholinergic drug, that is atropine. In anticholinergic poisoning, you should give cholinergic poisoning, no, common sense. So you have in the brain for delirium, no, it will not work. So you will not give quaternary amines. What is left? Tertiary amines. In tertiary amines, what are the drugs we have studied? Tacrine, donepezil, rivastigmine, galantamine. I've left out one single drug, that is physostigmine. It is physostigmine. So physostigmine is the drug of choice in anticholinergic poisoning or atropine poisoning or datura poisoning or atropa belladonna poisoning. Did you understand this much? That's all. We have covered all the drugs in the parasympathetic nervous system, most high yielding topic for the exam. That's all. Most high yielding. I promised you that I'll talk about physostigmine. Now I did. We'll go to that page and fill it up. Physostigmine is the drug of choice in anticholinergic poisoning. So now we will write. See, what is the drug of choice for atropine, datura and anticholinergic poisoning? It is physostigmine. What is the drug of choice for diagnosis of myasthenia gravis, short acting? Edrophonium. Now symptomatic treatment, what can we give? Long acting pyridostigmine. So you can see one theme here. Whenever you see the name stigmine or chol, both of them are cholinergic drugs. Okay. When you see the name trop, it is anticholinergic drug. That's all. It is anticholinergic drug. Easy way to remember this. Yes. Now, where do people get confused in the exams? So let us suppose they will ask you the symptomatic treatment of myasthenia gravis, which drug are we using? And in the options they will give both pyridostigmine and physostigmine. Both of them look the same. Always confusion happens here. So what can we do? You can see the spelling properly. Pyridostigmine. Yes. What is there? Y and R. Okay. C poison. That's all. We have done with all the drugs of parasympathetic nervous system. Now we will try to see how the questions are asked, and after that I'll give you 2 to 3 minutes for you to revise all of this ones. Okay. So we'll see this drug. Yes. Methacholine is used in the bronchial asthma challenge test. Okay, I've already told you this. The effect observed here is due to action on its which receptor. So you have to understand this. Methacholine, okay, cholinergic drug, it is used in bronchial asthma challenge test because the effect is bronchoconstriction. Yes. So bronchoconstriction means the effect is on bronchus. On bronchus, which receptor is present? I already told you. M1 is present in brain and stomach. M2 is in heart. I told you, mature person, no? M3 is in rest of the body. So M3 is present on bronchus. Answer is M3. That's all. This is the question that has been asked in NEET. So I told you, if you remember this flow and scheme, you will be able to answer even the new questions that you will get. That is why concepts are really important. Okay. So same thing. Next question. This is how questions are asked nowadays. They will not ask you what is the drug of choice for this. Unfortunately, they will not give you drug of choice for cholinergic poisoning and the options. That is in the olden days. Now they are giving you clinical scenarios. That is why I prepared these questions for you. Okay. A 48-year-old woman presents with 6 months history of gritty sensation in the eyes, difficulty swallowing dry food, and recurrent dental caries. Why? Because the salivation has decreased. No. Here there is decreased lacrimation. On examination, she has markedly reduced tear production. That is what I told you, decreased lacrimation. This is what is known as positive Schirmer's test. And there has been parotid gland enlargement, and the laboratory testing reveals anti-Ro antibodies. Anti-Ro antibodies. So anti-Ro antibodies, dry eyes, dry mouth, all of these can be seen in which syndrome? It is Sjogren's. I've already told you, in Sjogren's syndrome we can use pilocarpine, but which is better? Cevimelin. So what is the answer? Cevimelin. That's all. Ho gaya. Yes, easy to understand. Good. Now a 42-year-old farmer is brought to the Emergency department after accidental exposure to insecticides. Easiest question. He itself has told you that there is accidental exposure to insecticides. I already told you insecticides and pesticides are either organophosphate or carbamate. So there has been accidental exposure to insecticides while spraying his crops. There is increased sweating, salivation, lacrimation. On examination, he has meiosis, increased urination, his pulse is 50, so there is bradycardia. All the symptoms of organophosphate and carbamate poisoning. Respirations are labored. Why? Because he is having bronchoconstriction. Which of the following is the drug of choice in this condition? Easy. Cholinergic poisoning. What is it? Antimuscarinic drug. Which one? Atropine. That's all. Has been asked so many times in the exam. You should not get it wrong. Okay. Now, fourth one. A young female patient presents with ptosis, which repeatedly worsens in the evening and improves in the morning. Very classical point that has been asked here. Yes, you must have studied in medicine so many times. That is myasthenia gravis. In myasthenia gravis, we have ocular myasthenia gravis, ocular MG, and generalized myasthenia gravis. In ocular myasthenia gravis, eye muscles are affected, so there is ptosis. Did you understand? So, which drugs can be used for diagnosis this condition? Diagnosing this condition means myasthenia gravis. It is tension test. No, I already told you, short acting drug. Which one? Edrophonium, neostigmine, or pyridostigmine? It is edrophonium. So this is the answer. That's all. Easy to answer, isn't it? So next, a child presents with history of ingestion of unknown fruit. We don't know which fruit is it. Okay. He develops delirium, dry mouth, mydriasis, tachycardia, constipation. All of these are symptoms of anticholinergic poisoning. That is what we have studied. So in anticholinergic poisoning, we have to use cholinergic drug. That is a tertiary amine. What is this? It is physostigmine. So if you know the concepts, you don't even have to look at the options. That is what is physostigmine. That's all. Simple, isn't it? Now, so till now, we have finished the parasympathetic nervous system. Next, after doing the sympathetic nervous system, we'll go through the other questions. So, did you revise the parasympathetic nervous system? Yes, you understood parasympathomimetics and parasympatholytics. Now the schema is going to be the same. Now we'll start with the sympathetic nervous system. Again, in the sympathetic nervous system, we have two types of drugs. They are known as sympathomimetics and sympatholytics. I told you same schema. Sympatholytics. Sympathomimetics are also known as adrenergic drugs. Parasympathomimetics are known as cholinergic drugs. Why are they known as adrenergic drugs? Because major neurotransmitter is norepinephrine, that is also known as noradrenaline. That is why these are known as adrenergic drugs or anti-adrenergic drugs. That's all. These are the two classes of drugs we are going to study. Now, how did we start the PNS chapter? By studying about the neurotransmitter. The same thing we are going to do here. So, what is the neurotransmitter here? It is norepinephrine. So, it starts with tyrosine. Tyrosine is converted to dopa. Dopa is converted to dopamine. Now, this dopamine is going into the vesicle, and inside the vesicle, dopa is converted to norepinephrine. When the calcium comes in, this dopamine or norepinephrine will be released according to the situation. That is what I am saying. This is why I didn't tell you about sympathetic nervous system before. See, in sympathetic nervous system, if you see here, let us suppose this is an organ that is heart. This is an organ that is heart. The neurotransmitter is norepinephrine and the receptors are either alpha or beta. On the heart, you usually have beta receptors. Okay, this much you already know. But what I am saying is, in some areas, dopamine can also be released. Example, it can be released in kidneys, it can be released in a brain. Okay. So, in kidneys and brain, dopamine can be released. And there is one more exception. The exception is sweat gland. On the sweat gland, even though it is part of sympathetic nervous system, sweat gland has a receptor that is known as M3. Now, I told you, where are the receptors, muscarinic or nicotinic? The neurotransmitter is supposed to be acetylcholine. So, that is the reason why, if you remember, in the organophosphate poisoning, I told increased acetylcholine will cause sweating. Why? Because it acts on the M3 receptor on the sweat gland and it will cause sweating even though it is part of sympathetic nervous system. This is what I want you to understand. These are the exceptions. Exceptions are usually tested in the exams. So common is norepinephrine, but the other ones are dopamine and what? Acetylcholine in sweat glands. That's all. Now, also if norepinephrine acts on the adrenal gland, it will release epinephrine. This epinephrine is going into the blood and it is going into all the organs. If a substance is released into the blood going into the distant regions, this is also known as hormone. So norepinephrine is a neurotransmitter, epinephrine is a hormone here, and the minor neurotransmitters are dopamine and acetylcholine. This is what I want you to remember. Now what I am saying is tyrosine is converted to dopa, dopa is converted to dopamine, dopamine to norepinephrine, and norepinephrine is released. If it is in the brain, dopamine can also be released. Now this dopamine and norepinephrine will act on receptors that are known as alpha, beta. Now you can see here both of them are GPCRs. So alpha and beta are G protein coupled receptor. That's all. So if you understood this much, now what will happen to dopamine and norepinephrine? They will be taken back inside, and then they are metabolized by MAV and COMT. MAV and COMT. This is what is happening in the body. So either dopa or norepinephrine is released. When they are released, they are taken back, reuptake of norepinephrine and dopamine, and these are metabolized by MAV, monoamine oxidase, or COMT, catechol O methyl transferase. These are the enzymes, they will metabolize them. Did you understand this much? Yes. Why? Because all of these are monoamines. Dopamine is a monoamine, norepinephrine is a monoamine. Yes. Now epinephrine, norepinephrine, dopamine together are known as catecholamines. That is why we say it catechol O methyl transferase. Yes, that's all. Now if you understood the neurotransmitter, how it is produced, now we will see the receptors. What are the receptors? I told you we have alpha and beta receptors. So in alpha there are two types, alpha 1, alpha 2, beta 3 types, beta 1, beta 2, beta 3. How to remember it? Again I will tell you the same trick, it will be easy for you to remember. See, alpha means the most important person, no? So alpha receptor is supposed to be the most important receptor, alpha 1. So alpha 1 is the most important receptor. That means it should be present almost everywhere in the body. Yes, it is. I will tell you how. So what is the most important sense in our body? I figure it is vision. So on the eyes, alpha 1 is present. Okay, and it is also present in the prostatic urethra. Now all over the body we have blood vessels, so it is present in the blood vessels also. Now in the eyes, what is it doing? Sympathetic nervous system, so it should cause mydriasis. If it has to cause mydriasis, there should be contraction of radial muscles of iris. So it is causing a smooth muscle contraction. Now you should be able to tell me, it is GS, GQ or GI? Yes, it is GQ. So in the prostatic urethra, what will it do? It will again cause smooth muscle contraction. Yes or no? So it will cause smooth muscle contraction. That means urethra is contracted, urethra is closed. Now will there be urination? No. So that is why there is decrease in urination. That is happening because of alpha 1. Now what will happen to the blood vessel? Blood vessels also have smooth muscles, so there is vasoconstriction. This is what is very important. You have to remember alpha 1 receptor. Even if you remember the other receptors or not, alpha 1 is really important. If you forget all the other things, I want you to remember alpha and beta receptors. Okay. Next, alpha 2. See, almost all the receptors that I told you are present in the postsynaptic region. You can see this is synapse. After the synapse, you have alpha and beta receptors. But alpha 2 is a receptor that is present on the presynaptic membrane. Why is it present in the presynaptic membrane? Let us suppose if norepinephrine is released in a higher quantity, what will happen? Yes, they will act on alpha receptors, beta receptors on the postsynapse, but the excess quantity will go into the presynaptic membrane and it will activate this alpha 2. What will this alpha 2 do? It will decrease the release of norepinephrine. It will do what? Decrease the release of norepinephrine. That means it is breaking the release, stopping the release. That is why we call alpha 2 as a brake. Because alpha 2 will decrease the release of neurotransmitter. That's all. So alpha 1 ice, prostatic urethra, blood vessels, alpha 2 is a break. That's all. Now coming to the beta receptors. How do you remember this? I told you muscarinic receptors are mature receptors. So it listens to the brain and fills up its stomach. Now beta. How do you write beta? BETA. BETA means beta, no? Beta means small children, no? So small children are immature, don't you think? So what will immature people do? I told you in the previous story, immature people will first listen to their heart. So beta 1 is present in the heart. That is how you can simply remember the muscarinic and beta receptors with help of one story. So in the heart, it activates SA node, increases heart rate, activates AV node, increases what? Conduction. Acts on myocardium, increases contraction. You can see it is causing stimulation of cardiac muscle and the AV node, SA node. So it is GS, it is stimulatory. GS, that's all. Now beta 3 is the last receptor, so it is present in the last organ, it is in the bladder. This is what is very, very important. Please concentrate on the bladder. MCQ. Okay. On the bladder, what is beta 3 doing? What is it doing? Try to think. Sympathetic nervous system. That means it will block urination, it will cause relaxation. So it will cause relaxation of smooth muscles of bladder. This much you already know. Then it should be GS, but this is not as what is important. What is important here, it is used in overactive bladder. It is used in overactive bladder. If you remember the overactive bladder, we have studied of the stimulated bladder. So in the overactive bladder, you can also use beta 3 agonist. Yes, because it is causing relaxation of smooth muscle. What are beta 3 agonists? They are, please remember, mirabegron and vibegon. Now, why is this so important? I will tell you. Mirabegron and vibegon are actually the drug of choice in overactive bladder. It is drug of choice in overactive bladder. So, if I ask you, a person is having overactive bladder with dementia, which drug will you give? Trospium, solifenacin or mirabegron? Obviously, the answer is mirabegron. Why? Mirabegron is the drug of choice anywhere for overactive bladder. Did you understand? So, the drug of choice for overactive bladder with dementia is mirabegron, vibegon, because beta 3 receptors are not present in the brain, muscarinic receptors are present. So, how can the question be asked? Overactive bladder with dementia, drug of choice, mirabegron or vibegon. Now, if they ask you anti-muscarinic drug, you will write trospium. If trospium is not in the options, you will write soli or darifenacin. So these are the MCQs that can be framed in the upcoming exams. Please concentrate on this. That's all. That is about the beta 3 receptor. Now coming to the beta 2 receptor. Beta 2 receptor is present everywhere else in the body. Where else? First we will see skeletal muscles. Yes, it is also present on cardiac muscles. Yes, it is also present on smooth muscle. If it activates the skeletal muscle, it will cause contraction. Activates the cardiac muscle, contraction. If it contracts too much, it might cause tremors, it might cause palpitations. Increased contraction of heart will cause palpitations, isn't it? Now, smooth muscles, where are they present? They are present in the bronchus, so it will cause bronchodilation. They are also present on the uterus, so it will cause uterine dilation. Why? Think about it. Contraction here, you already know. Why? Because it is GS. I already told you bronchus and uterus. In bronchus, in sympathetic nervous system, there is bronchodilation. Bronchodilation means smooth muscle relaxation. Smooth muscle relaxation should be GS. So GS will activate the other muscles. That is why we have skeletal muscle contraction, cardiac muscle contraction. Did you understand this much? Yes. Now, what is most important? Whenever a person is having hypoglycemia, it is an emergency. Emergency will activate the sympathetic nervous system, especially the beta 2 receptor. When beta 2 receptor is activated in the liver, it will increase the glucose. And in the pancreas, it will act on the beta islet cell and it will increase the insulin release also. You might ask me, if glucose is increased, insulin is really increased, insulin is supposed to decrease glucose, no? See, what I am telling you is, there is lot of increase of glucose. There is some increase of insulin. Now, this increase in glucose is much more in comparison with the insulin. That is why still you will have increase in glucose levels. Okay, good. So, insulin will also reduce the potassium levels if insulin is increased. Why am I telling you this? From this you will get 1 or 2 MCQs. I will tell you while we are discussing the MCQs. So, this is what I want you to understand. Alpha is present in the eyes, prostatic ureter, blood vessels. Alpha 2 is a brake. Beta 1 is present on the heart. Beta 3 is in the bladder. Beta 2 is present rest of the body. Yes, good. Now coming to the sympathomimetic drugs. I told you, everywhere it is going to be the same. So we have two classes of drugs. What are they? Direct acting, indirect acting. How does direct acting work? They act directly on receptor. Indirect, they will increase the neurotransmitter. So direct acting, indirect acting, and in this we have mixed acting. What is mixed acting? It is nothing but it has both the effects. That's all. It acts directly on the receptor and it also increases the neurotransmitter. Nothing new. Okay. Direct acting, indirect acting. We will see all these drugs. So, first coming to the direct acting drugs. In direct acting drugs, see, in the body we have neurotransmitters and hormones like norepinephrine, epinephrine, dopamine. That is what is activating the sympathetic nervous system. So what did we think? Why don't we make the same things that are present inside the body? They will act on the sympathetic nervous system. True, that is what the scientists have done. Now, these are also known as endogenous catecholamines. Why? Epinephrine, norepinephrine, dopamine are catecholamines. They are present inside the body, so they are known as endogenous catecholamines. This is what I want you to remember. Epinephrine and norepinephrine will almost act on all the receptors, alpha 1, alpha 2, beta 1, beta 2, beta 3. Yes, only exception is norepinephrine will not act on beta 2. This is what I want you to remember. When it is not acting on beta 2. See, beta 2 is a GS receptor, so it will cause relaxation of smooth muscle. So, smooth muscle is also present on blood vessel. Do you accept? It will cause vasodilation. This is one very important concept. That is why I told you in the end. So alpha 1 is causing vasoconstriction, beta 2 is causing vasodilation. How can you remember this? You can write it as A, B, C, D. A first alphabet, B second alphabet, alpha 1 vasoconstriction, beta 2 vasodilation. At least this much you should know. Now, see here. Epinephrine is a potent cardiac stimulator. That means it works mainly on the heart. So it is drug of choice in cardiac arrest. It is drug of choice in cardiac arrest. Since it is a potent cardiac stimulator, it is drug of choice in cardiac arrest. Okay. Now coming to the norepinephrine, it is a potent vasoconstrictor. That means it will constrict the blood vessels very well. If there is vasoconstriction, it will increase the BP. So this will increase the BP. It can be used wherever BP is less, especially in the shocks. Now, it is drug of choice in vasodilatory shock. That's all. Why? Because there is vasodilation. Because of vasodilation, there is drop in blood pressure. That is what is vasodilation, vasodilatory shock. So, norepinephrine is the drug of choice in vasodilatory shocks. Yes, you must have heard neurogenic shock, all these shocks. Now, there is something known as anaphylactic shock. This is also a vasodilatory shock, but in anaphylactic shock, the drug of choice is epinephrine. Why is that? That is the most important thing that you need to understand. Because in anaphylactic shock, there is bronchoconstriction. Now you can cause bronchodilation only with beta 2. Only epinephrine is acting on beta 2, that is why we give epinephrine here. The doses are what is important. In cardiac arrest, we will give 1:10,000 IV, and in anaphylactic shock, we give 1:1000 IM. Most commonly asked in the exam. This is what is very important for the exam. Okay. Now, if you understood this much, dopamine. Dopamine has a dose dependent action. It works on different receptors based on the dose. So, how can you remember this? It acts on 3 receptors. Dopa, you can write it like this. DOPA, dopa. Yes. So, in the low dose, it acts on D1 receptor. Yes. Now, It is dopa. Next, P, you can write it like this. It looks like beta. O means 1. So D1, beta 1 and A1, that is alpha 1. So in the lower dose it acts on D1, in the medium dose it acts on beta 1, in the high dose it acts on alpha 1. This is how you can remember the receptor functions of dopamine. It is usually given in the microgram per kilogram per minute, but these doses are not important at your level. Now this can be used in a patient who is having shock with oliguria. Why? D1 receptor is present on the kidney, and D1, D for D, it will cause diuresis. Diuresis means increased urine output, so it can be used in oliguria, shock with oliguria, dopamine, that's all. Norepinephrine, potent vasoconstrictor, so vasodilatory shock, except for anaphylactic shock where we use epinephrine, cardiac arrest, epinephrine, that's all you have to remember in this. Now, then what did we do? We try to make the catecholamines that are not present inside the body. They are known as exogenous catecholamines. Exogenous catecholamines. There are many names: isoprenaline, phenaldopamine, dopexamine. All of these you don't have to remember. One thing I wanted to remember is dobutamine. Dobutamine works especially on the beta 1, and this is drug of choice in acute congestive heart failure. Dobutamine is drug of choice in acute congestive heart failure. That's all. Now, if you understood this much, so usually in the exam they'll ask something about epinephrine. When you give epinephrine, when you first give epinephrine, it is in higher quantities in the blood. When it is in higher quantities, it will act on alpha 1. When the quantity decreases, it will act on beta 2. This is what I want you to remember. So what will happen? When you first give, it will act on alpha 1. It will cause vasoconstriction and it will increase the blood pressure. Okay. When the dose decreases, it will cause vasodilation and it will decrease the blood pressure. So this is what is happening normally. This is the phenomenon or biphasic pattern of BP that is given by Dale. Okay. Now what Dale is saying is, if you give epinephrine along with alpha blocker, that means it will block the alpha receptor. Will you get this increase in BP? No. You will only get the decrease in BP. That is what is known as vasomotor reversal of Dale. It is seen in the graph very easily. The graph has reversed. That is what is known as vasomotor reversal of Dale. That's all. Easy to understand. This is the question that has been asked so many times in the FMGE exam. Vasomotor reversal of Dale. When you give alpha blocker along with the epinephrine, this is what can happen. The BP can decrease. Please try to understand this much. Next, we have finished with the catecholamines. Now, the other one is non-catecholamines. That means they don't look like catecholamines at all. Endogenous catecholamines, exact catecholamines. Exogenous means these look like catecholamines but they are not in the body. Now, the next classification is non-catecholamines. Now, what can be the drugs? You have 3 receptors. No, what are they? Alpha 1, alpha 2, beta 1, beta 2, beta 3. So we can have these many classes of drug. Alpha 1 agonist, alpha 2 agonist, beta 2 agonist, beta 3 agonist. But beta 1 agonist, we already have one drug that we have studied in exogenous catecholamines. Do you remember? Dobutamine. So we did not make anything else. But there is alpha 1 plus 2 here. So these are all the non-catecholamines that are present. Now we will see the most important ones for the exam. Now, how to remember these names? Alpha 1. Alpha 1 means it is causing what? Vasoconstriction. So it can be used wherever the patient is having vasodilation. Okay, good. Use wherever patient has increased vasodilation. Okay, because it is causing vasoconstriction. Good. Alpha 1 agonist. How to remember? I told you. Alpha means most important person. Alpha 1, alpha 2. Now you tell me, who is the most important person in the country? Obviously, it is PM. So alpha 1 are PM drugs. Alpha 2 means second most important. Now, after country comes the state. So state is CM. So alpha 1 is PM drugs. Alpha 2 is CM drugs. Done. So alpha 1 is phenylephrine, midodrine. You can use it wherever you require vasoconstriction. Where do you require vasoconstriction? There is a problem called priapism. Priapism means uncontrolled erection. Why does erection happen? Because of vasodilation. So if you cause vasoconstriction, will you treat this? Yes. Now, midodrine is drug of choice in postural hypotension. Why? Why does hypotension happen? Because of vasodilation. So if you cause vasoconstriction, will you treat this? Yes. Next, coming to the alpha 2 agonist. I told you, remember two drugs, CM drugs. What are they? Clonidine and alpha methyl dopa. Clonidine and alpha methyl dopa. Now, the most important thing that I want you to understand is, all of these drugs are sympathomimetic drugs. But alpha 2 is a brake. So if you give alpha 2 agonist, norepinephrine will decrease. If norepinephrine is decreasing, these sympathetic functions are decreased. So alpha 2 agonist, even though I am saying it in the sympathomimetic drugs, these are sympatholytic drugs. Why did I keep it in this chapter then? To maintain the continuity of this non-catecholamines, I have placed it here, but these are sympatholytic drugs because it is decreasing the neurotransmitter. Please get this into your head. Did you understand? Clonidine and methyl dopa. So if it is sympatholytic drug, yes, will it increase the BP or decrease the BP? Obviously it will decrease the BP. That is why we use it in hypertension, especially a patient who is having chronic hypertension in pregnancy. In gynecology, you study what is chronic hypertension in pregnancy and pregnancy-induced hypertension. In chronic hypertension in pregnancy, you will use something known as methyl dopa. Yes, you will use something known as methyl dopa. Next, coming to clonidine, there are a lot of uses of clonidine. It can be used for hypertension, true. It can be used for lowering the withdrawal symptoms of opioids, true. And the most important function I will tell you in some time. Okay. Now, in the NEET PG, there has been one question that is about tizanidine. Tizanidine is a muscle relaxant. NEET PG में पूछा था. Yes. For FMGE, please remember clonidine and alpha methyl dopa. It is done. Alpha 1 PM drugs, alpha 2 CM drugs. Now, alpha 1 plus 2 agonists, they are xylometazoline and oxymetazoline. These can be used in allergic rhinitis. Why in allergic rhinitis? There is vasodilation of nasal vessels, so you can use it in allergic rhinitis. That is what you see in Otrivin drops. These are those. Next, most important is beta agonist. Now, beta, I told you there is no beta 1. Next is beta 2. Beta 2, where are they present? It is present everywhere else in the body. Aren't they present on the bronchus? Yes, if it is present on the bronchus, it will cause vasodilation. So, it can be used in bronchial asthma. Do you remember Sama, Aima, Lama? Same here. Saba, Laba and Vilaba. What is important to us? Saba is terbutaline salbutamol, Laba is formoterol. Please remember this much. That's enough. It is used in bronchial asthma. Now, ritodrin. Ritodrin can be used for uterine relaxation. It is used. It will cause uterine relaxation. That's all about beta 2 agonist. Good. Beta 3, told you so many times, mirabegron, bibegron. It is drug of choice in overactive bladder. What is drug of choice in overactive bladder? With dementia, mirabegron. Antimuscarinic drug, trospium. If trospium is not there, next, sulfenacin, darifenacin. This is what I want you to remember. This concept is really important. How can you remember the drug names? I told you overactive bladder means there is increased activity of the bladder. That means excess activity of the bladder. So you can remember it like this. Mirabegron. Yes or no? So what I'll try to remember is Mira means Mera, B means bladder, E means excess activity. Mera bladder excess activity gone. That is mirabegron. V means we, all of us. Vibegron, our bladder excess activity gone. So mirabegron, vibegron are the drug of choice in overactive bladder. This is how I remember these drugs. Okay, good. Next, that's all about the direct acting drugs. Next, coming to the indirect acting drugs. Indirect acting drugs means it should increase the neurotransmitter. That means, let us suppose if norepinephrine is present in the vesicle, if it pushes the norepinephrine outside, that is what is known as norepinephrine displacer. Examples are tyramine and amphetamines. Now, this norepinephrine is being reuptaken, so you can block this. These are uptake inhibitors, and after this they are metabolized by MAO and COMT. You can block these. These are MAO and COMT inhibitors. So these are the 4 classes of drugs. That's all. So norepinephrine displacer, uptake inhibitors, MAO inhibitors, COMT inhibitors. In all of these, what are important? Amphetamine. Amphetamine-like drug is methylphenidate. Methylphenidate is the drug of choice in ADHD. Now, in these drugs, what are the important points you have to remember? I have given it in the table. We'll try to see this. What is the drug of choice in priapism? It is phenylephrine. I've already told you. Now, in chronic hypertension in pregnancy, which drug would you use? It is methyl-dopa. ADHD, I told you, what is the drug of choice? It is methylphenidate. Please remember this. Methylphenidate. Now, if you give a methylphenidate in a patient with ADHD, if the patient has tics, it will worsen the tics. So, in this patient, you will give clonidine. Very important topic in psychiatry. ADHD, methylphenidate, ADHD with tics, clonidine. And in psychiatry, there is one more drug, ADHD with family history of addiction. There you give atomoxetine. Okay. Now, postural hypotension, you give midodrine. This all you know. Only thing I have added is methylphenidate. And what is the drug of choice for narcolepsy? It is modafinil. So this is what I want you to remember for indirect acting drugs. And mixed acting drugs, we don't use it nowadays anymore. These are ephedrine, pseudoephedrine, norepinephrine. Yes, they are not used anymore. So again, for clinical importance, direct acting, indirect acting. Direct acting only we have studied, mostly concentrate on the catecholamines. Then they might ask you the vasomotor reversal of Dale. Yes, after all of this, then you have to study about the beta 2 agonist. Now, most important and commonly asked question are, what are the side effects of beta 2 agonist? What are the side effects? Whenever beta 2 receptors are activated, I already told you, in the skeletal muscles, it will cause tremors. In the cardiac muscles, it will cause palpitations. In the liver, it will increase glucose, hyperglycemia. If it is increasing insulin, it will decrease potassium. Most important question. They will give these 4 options and change one of the things. They might even give you hypoglycemia or hyperkalemia. That is the wrong option. They will ask you which is not the side effect of beta 2 agonist. So, if you understood this much, this is more than enough when it comes to sympathomimetics. Okay. So, have you revised the sympathomimetics? We have talked about the catecholamines and non-catecholamines, and then we have seen the indirect acting drugs like uptake inhibitors, norepinephrine releasers like tyramine and amphetamines. Yes, now we will start with the sympatholytics. They are also known as anti-adrenergic drugs. I told you the same concept here also. So there are going to be 2 classes of drugs. What are these classes of drugs? Direct acting drugs and indirect acting drugs. Direct and indirect acting drugs. Okay. So direct acting drugs means they are blocking the receptors directly. So how many receptors do we know? Alpha and beta. So we are going to study about the alpha blockers and the beta blockers. One beta blocker that we have already studied is propranolol. Okay. Now we'll start with the alpha blockers. These are direct acting drugs. Now in alpha, how many receptors do we know? We have alpha 1 and alpha 2. If we block both the receptors, alpha 1 and alpha 2, we call it non-selective. If we block only alpha 1, we call it selective alpha 1 blockers. So, easier way to remember is, since non-selective is blocking both alpha 1 and alpha 2, you can think that it is a strong vasodilator because it is blocking 2 receptors. Think of it this way. Yes, it is a strong vasodilator. So, it can be used in emergencies. Okay, it can be used in emergencies, that is due to vasoconstriction. Means vasoconstriction will cause increase in blood pressure. So there is increase in blood pressure and emergencies related to this. Do you remember those 2 emergencies? What are they? One is cheese reaction. The other one is clonidine withdrawal hypertension. Now these 2 are emergencies or crisis that is happening cheese reaction and clonidine withdrawal hypertension. Here you can give non-selective alpha blocker. In non-selective alpha blocker, you have to remember two. One is phentolamine. Phentolamine is what is drug of choice in cheese reaction and clonidine withdrawal hypertension. The other one is phenoxybenzamine. Phenoxybenzamine. This is used in pheochromocytoma. How to remember both of these? Easy. P for P. Yes. And see the length of this name? Almost the similar length. So the big drug for the big condition, and phentolamine for cheese reaction and clonidine withdrawal hypertension. Okay. Phenoxybenzamine for pheochromocytoma. This finishes the alpha blockers that are non-selective that are asked in the exam. Now coming to the selective alpha 1 blockers. Selective alpha 1 means it is blocking only alpha 1. Now unfortunately in alpha 1 again we have three receptors: alpha 1A, alpha 1B, alpha 1D. Now how did we remember the alpha receptor? If you can recall it, alpha 1 is the most important, so it is present on the most important sense, that is I. So it should be alpha 1A. So on the I and prostatic urethra we have alpha 1A. Now B and D receptors, these are present on blood vessels. B and D, these are present on blood vessels and they will cause vasoconstriction. And in prostatic urethra, exactly where is it present? It is present on internal ureteric sphincter and it will close this. This is what alpha receptor is doing. That is why I told you alpha receptors are a must know. You must remember these receptors even if you cannot remember the other ones. So how did I remember this? Alpha 1A eyes and in the prostatic urethra. B and D. You can see here BD. If you smoke BD, it will damage blood vessels. No? So that is how I remembered. Anywhere you see B and D, subtypes of B and D, they are mostly present on the blood vessels. If you understood this much. Again in selective alpha 1 blockers, we have two classes. One is blocking all these three receptors, 1A, 1B, 1D. The other one is blocking only 1A. Now what is important here? If 1A is blocked, 1A is present where? In the internal ureteric sphincter, it is closing it. So it will open the internal ureteric sphincter. So this can be used in a condition known as BPH. Why BPH means benign prostatic hyperplasia. Let us suppose this is urinary bladder and this is the urethra. Then there is prostate gland. If the prostate gland is increased in size, it will compress this urethra and the person is not able to urinate properly. This happens in old people. Now, if you give alpha 1A blocker, it will open this sphincter a little and it will relieve the symptoms. So it can be used in BPH for symptom relief. Please try to understand this. It will not decrease the size of the gland. It is only used for symptomatic relief. Now, B and D will cause vasoconstriction. If you block this, it will cause vasodilation. So it can decrease the BP. So it is drug of choice in patient with BPH with hypertension. Yes, what are the drugs? All these zosins, prazosin, terazosin, alfuzosin, doxazosin, any zosin, you know, all of these drugs are alpha 1ABD blockers. Now, there is one special side effect for this. Because it is decreasing the BP, it can cause postural hypotension. So, what if a person is having only BPH? Would you like to give this drug? No. Why? Because it is causing postural hypotension. No, you don't want to cause postural hypotension in a normal patient. So, in this people, we have made one more drug. This is super selective. It is only acting on the 1A. If it is acting only on 1A, it will only open IUS and it can be used in BPH. So it is drug of choice in BPH. How can you remember this? Silodosin, tamsulosin. This is prazosin, this is silodosin, tamsulosin. Did you understand this much? Yes. Now, we will see here alpha 1A, 1B and 1D blockers. Examples are prazosin, terazosin, doxazosin, alfuzosin. Now, this is used in BPH with hypertension. Okay. Prazosin is also the drug of choice in scorpion bite. So it can be used also in scorpion bite. Now the problem with this is, if you can see here, both of these drugs are blocking alpha 1A receptors. So both of them will have some common side effect. What is the special side effect of alpha 1A BD? It is postural hypertension. But because it is blocking alpha 1A, it will have some common side effects. These are very, very, very important. What are these? Alpha 1A is present in the eyes. So if you keep on blocking the alpha 1A, then if it is activated, if you are blocking it, if you are activating it, so what is happening? The iris becomes floppy. So it will cause floppy iris syndrome. Alpha 1A is also present in the prostatic urethra. Yes, if the prostatic urethra is opened, now during ejaculation, we need the movement of prostatic urethra, contraction and relaxation. Here, this is opened forever, or it is opened for some period of time, so there will be no proper ejaculation. So if the ejaculate is not coming forward, it will go backward. That is what is known as retrograde ejaculation. And then there is no ejaculate coming out. That is what is known as ejaculation failure. So you see all of these with both classes of drugs. Now maximum side effects are seen with silodosin. Why? This is only blocking alpha 1A, so it will act mostly on alpha 1A. Yes, it is not acting on B and D, it is only acting on alpha 1A, so it is powerful blocker. So silodosin and tamsulosin will have maximum side effects. How to remember this? See, both of them are sexual side effects. So sexual side effects, S for S, maximum and silodosin. Very, very, very important topic. Most probably they'll ask you about the alpha blockers. If they're asking about the non-selective ones, it should be phentolamine or phenoxybenzamine. If they're asking about the selective ones, it can be prazosin or the other one is silodosin, tamsulosin. Did you understand? So next, going to the beta blockers. Beta blockers you'll study everywhere in the cardiovascular system. Okay, all of these are ending with lols, with the name lol in them. Any lol is beta blocker. First drug we have made, that is prototype drug, is propranolol. In this we have 3 generations of drugs. What are they? First generation means it is non-selective. Obviously it will block both beta 1 and beta 2. So if it is blocking beta 1, what will it do? It will decrease the heart rate. So it can be used in patients who are having increased heart rate and stuff. Yes, you will see it in cardiac heart failure. Chronic heart failure. You will also use it in patients with hypertension. You will study all of this in CVS. Now, if it is blocking beta 2 is what is causing vasodilation. If you are blocking this, it will cause vasoconstriction. Is vasoconstriction good? No, obviously. Why? Vasoconstriction can increase the BP, and most probably the worst part is it can also cause erectile dysfunction. That is why we don't prefer first generation. So we have made second generation. What is second generation? It is cardioselective. That means beta 1 is present only on the heart. So we have made second generation which is acting mostly on beta 1, some activity on beta 2. So that is why it is known as cardioselective. But there is still some activity on beta 2, so there is still minimal vasoconstriction. So what did we do? We tried to make a third generation of drugs. In this, there is an additional property to these drugs. What is the additional property? Vasodilation. Additional property is vasodilation. Okay. Now, it doesn't matter where these drugs are acting on, which receptor. It can be cardioselective or it can be non-selective. It does not matter. Okay. So, third generation drugs will have both cardioselective and non-selective drugs, but they have an additional property that is known as vasodilation. This is what I want you to understand, the subtle differences, the subtlety most of the people don't get. If you understood this much, now I've given the classes of beta blockers. First generation, these are non-selective. Then I've written cardioselective. Second generation is cardioselective, and third generation cardioselective also I've added here. So this is the second table. Third table is third generation and non-selective. So this is the table you have to go through about the lols. Yes. Now I told you some stories during the classes about the TEM, sotalol, nadolol and all of this. But we don't have that much of time, and this is also not needed for the exam. But what you can remember is nadolol is the longest acting beta blocker. Nada means, no, nada that you used to tie for the pants in Hindi. So these are usually long, so you can remember this is the longest acting. What about the shortest acting? Shortest acting is esmolol. Esmolol is the shortest acting according to the textbook. Now there is a new drug that has been approved, that is what is known as landiolol. Landiolol is even shorter acting than the esmolol. Yes, I am not going to give you a mnemonic for this because my students have made a very creative mnemonic. People who know Hindi will understand this, so I am not going to make it. Yes. So coming to the cardioselective drugs, how do you remember this? There is a mnemonic, that is new beta blockers. New beta blockers act exclusively at myocardium. That is the statement. No, cardioselective means it acts exclusively at the receptors of myocardium. That is what I told you. New beta blockers act exclusively at myocardium. New is nebivolol, beta is bitoxolol, blocker is bisoprolol, act is acebutolol, exclusively is esmolol, at is etinolol, myo is metoprolol, cardium is celiprolol. Now what is important? First two, nebivolol, bitoxolol, and the last drug, these are third generation, rest all are second generation. Now what is the most important drug in all of this is carvedilol. Why is this so important? Carvedilol is a calcium channel blocker, alpha blocker, beta blocker, and it also reduces the oxidative stress. How can you remember this? C for calcium channel blocker, A for alpha blocker, R for reduces the oxidative stress. This is what I want you to remember for now. Okay, so these are about the beta blockers. Now in the beta blockers, about the propranolol. Propranolol is also drug of choice in infantile hemangioma, akathisia, migraine prophylaxis, portal hypertension, tremors, and thyroid storm. So we will study this respectively in their chapters. Yes, for people who have attended the classes, I have made a big story on the beta blockers. If you know this, you will understand all the users, side effects, and contraindications of this. But for now, remember this much for the exam. Okay, good. So this is about the direct acting drugs. What about the indirect acting drugs? See, indirect acting drugs means they should block the synthesis of norepinephrine and dopamine. Now, there are many drugs like metyrosine and stuff, we don't use them, but the most important drug that we actually use is VMAT2 inhibitors. VMAT2 inhibitors. See, if the dopamine has to go into the vesicle, this has to be transported through VMAT. VMAT means vesicle monoamide transporter. If we block this, will dopamine go inside? No, it will not go inside. So dopamine levels will decrease, isn't it? What are the drugs? Reserpine. We don't use it anymore because it is causing depression. If the side effect is depression, the people will die, isn't it? So the next one is valbenazine, tetrabenazine, deutetrabenazine. So all these drugs are VMAT2 inhibitors. These are actually used. Yes, about these uses we'll study it in the CNS chapter while we are studying the schizophrenia. Okay, so these are the indirect acting drugs. We'll study it there. Now, alpha blockers, beta blockers, alpha blockers are very important, especially the phentolamine, prazosin, and silodosin. You have to know this. So this is about the sympatholytics. If you understood this much, then we'll try to solve the MCQs and we'll go into the next chapter. Okay, so you can see here a 60-year-old man with heart failure with reduced ejection fraction, that means HFrEF, is being treated with carvedilol. Okay. He also has type 2 diabetes mellitus, for which he is on oral hypoglycemic agents. Okay. After fasting for 2 days, he develops hypoglycemia. I told you, hypoglycemia is an emergency, no? So it will activate what? Sympathetic nervous system. So what will sympathetic nervous system do? It will release norepinephrine. It will act on beta receptors. Good. When it acts on beta receptors, what will happen? It will increase tremors, it will increase palpitation, it will increase glucose. Great. Now, but what is the question? Which of the following symptoms is most likely to point towards hypoglycemia in this patient? So, all these things will be seen whenever the patient is having hypoglycemia, and all of these are happening because of beta receptor. But here the patient is on carvedilol. This is what is very important. He is on carvedilol. Now carvedilol will block this beta receptor. It will block everything. Now when sympathetic nervous system is activated, if you remember the sweat gland, it has M3 receptor. On this acetylcholine will act. Did you understand? Can carvedilol block this? No, because it is not beta receptor, no. So you will still see sweating. That is the reason why you will still see sweating in a patients who are having hypoglycemic awareness with use of beta blockers. See, beta blockers are not generally given in diabetes mellitus. This is the reason. It masks all the symptoms of hypoglycemic awareness except for sweating. Good. Now, next one. A 55-year-old man suddenly collapsed while jogging, okay, is brought to the emergency department where he is found to be pulseless and unresponsive. So, he is gone into asystole. You can say it cardiac arrest, okay. Cardiopulmonary resuscitation is started CPR and the decision is made to administer epinephrine, okay. Common sense, cardiac arrest, epinephrine. Which of the following is the correct formulation and route of epinephrine administration in this setting? If you already know the answer, try to remember it in the head itself, because seeing in the options you might get confused. Cardiac arrest you already know, you should give it in IV, and what is the dose? 1 is to, what is the dilution? 1 is to 10,000. You can see here, where is it? 1 is to 1000, no. 1 is to 1000, no. 1 is to 10,000, okay, but IM, no. It is 1 is to 10,000 IV. This is the answer. What about 1 is to 1000 IM? It is for anaphylactic shock. Anaphylactic shock. Yes. Coming to the 8th question. A 25-year-old male presents with recurrent episodes of shortness of breath and wheezing. Okay. He has been prescribed inhaled salbutamol for symptomatic relief. Maybe he is having asthma and he's been given salbutamol. Okay. Which of the following adverse effects is least likely, please, least likely to be associated with this medication? Okay. Now, what is the person having? He is using the beta 2 agonist. I have already told you, this is the question that has been asked so many times. Beta 2 agonist, they will cause tremors and then they will cause palpitations. So these are not the answers. Okay, and it will increase the glucose. Yes. Hyperglycemia, not the answer, but it will decrease the potassium. Hyperkalemia, this is the answer. This is not seen. Hypokalemia is seen. Did you understand? Now, going to the next question. A 45-year-old man with a history of depression has been on treatment with a MAB inhibitor. He is using MAB inhibitor. Okay. One evening after consuming wine and cheese. Wine and cheese will have what? Tyramine. It is norepinephrine displacer. He suddenly develops headache, palpitation, sweating and flushing. On examination, his blood pressure is 190 by 120 mmHg. He is rushed to the emergency department. Which of the following drugs is most appropriate for the immediate management of this patient? So, if you see here, a person is using MAB inhibitor and is getting tyramine. It could be from cheese or something. It will cause hypertensive crisis. This is what you must have studied. This is what is cheese reaction. So, what is the drug of choice in cheese reaction? It is phentolamine. What about phenoxybenzamine? It is used in pheochromocytoma. Pheochromocytoma. That's all. Now, so that's all about the sympathetic nervous system. Now we'll start with the renal system. First, let us start with the anatomy and physiology of nephron. Then we'll see all the diuretics that are needed for the exam. Okay. So, looking at here, what are the parts of nephron? You can see this part, this is Bowman's capsule, then there are tuft of capillaries, this is glomerulus, then there are tubules. There are folds that are convolutions, so they are known as convoluted tubules. This is proximal, so you call it proximal convoluted tubule. Here you have a distal convoluted tubule as well. In between both of these, you have a loop. This loop is known as loop of Henle. Why? Because the scientist's name is Henle. He is the one who has given this loop. So this is known as loop of Henle. Then finally we have collecting duct. So these are the parts. That's all. So what are the parts? That is glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle, then distal convoluted tubule which opens into the collecting duct, and from the collecting duct the urine is coming out. So this is what is basically happening in the nephron. Now, whatever is filtered from the blood, it goes into these tubules and most of the filtrate is reabsorbed. Most of it is reabsorbed. When it comes to sodium, almost 99% of sodium is reabsorbed. How? I'll tell you. See, in the PCT, we have an antiporter that is known as sodium hydrogen antiporter. In this, the sodium is reabsorbed and H plus is going outside. So, here this absorbs 67% of sodium. This absorbs 67% of sodium. Now, coming into the loop of Henle, we have a descending part, that means it is going down, and then there is an ascending part. In the ascending part, we have both thin and thick. So, this is thick ascending loop of Henle. In the thick ascending loop of Henle, we have sodium potassium 2 chloride channel. Sodium potassium 2 chloride channel. It will reabsorb sodium, potassium and chloride as well. In here, 25% of sodium is reabsorbed. Now, in the DCT, we have a channel that is known as sodium chloride symporter. So, in here, sodium is being reabsorbed. Sodium is being reabsorbed. How much? Around 5%. Now, 1 to 2% of sodium will be reabsorbed in the collecting duct. Now, this is cortex, this is medulla. So, we call the upper part cortical collecting duct. In the cortical collecting duct, when the hormone aldosterone acts, yes, this is that renin-angiotensin-aldosterone system. When aldosterone acts, it will produce a channel that is known as ENaC channel. From this, 1 to 2% of sodium is reabsorbed. So, what did I tell you? 67% in the PCT, 25% in the TAL, thick ascending limb of Henle. Next, 5% in the DCT via sodium chloride symporter and 1 to 2% by the ENaC channels. So, this is the basic anatomy and physiology. If you understood this much, the diuretics are going to be really easy. Now, what is the first class of the diuretics? These are known as carbonic anhydrase inhibitors. These are known as carbonic anhydrase inhibitors. Now, what will these carbonic anhydrase inhibitors do? They will indirectly block this sodium hydrogen antiporter by blocking the carbonic anhydrase enzyme. That is why they are known as carbonic anhydrase inhibitors. Yes. Now, what will happen when you block this sodium hydrogen antiporter? Sodium reabsorption is decreased. When sodium is not reabsorbing, the sodium will be lost through the tubules into the urine. Now, wherever sodium goes, water follows. So, there will be loss of sodium and water. This is what is known as diuresis. So, what is the mechanism of any diuretic? So, if you block any of the sodium channel reabsorption, what would happen? The sodium will go outside, along with the sodium, water will go outside. This is what is known as diuresis. So, did you understand the mechanism of diuretics now? First class is carbonic anhydrase inhibitors. This will block the carbonic anhydrase enzyme, and this will in turn block this sodium hydrogen antiporter. The sodium is not reabsorbed. This will be going out in the urine. This is what is the diuretic effect that we are talking about. Now, what are some of the examples of carbonic anhydrase inhibitors? I want you to remember one thing, that is acetazolamide. Acetazolamide. Now, this is drug of choice in acute mountain sickness. This is drug of choice in acute mountain sickness. We have seen this MCQ before. Do you remember? If there is motion sickness, it is scopolamine, but if it is acute mountain sickness on the top of the mountain, that is acetazolamide. Now, coming to the next class of drugs, if we block sodium potassium 2 chloride, what will happen? Sodium will be lost, water will be lost. So, these are also diuretics. These are loop diuretics. Why? Because it is acting on loop of Henle. Yes, that's all. Now, what are the examples of this? Torsemide, furosemide and ethacrynic acid. Now, where can we use this loop diuretics? Loop diuretics are drug of choice in acute pulmonary edema. Acute pulmonary edema. Now, they can also increase the GFR. So, you can use it in patients who are having renal problems. Yes, because it is increasing the GFR. This is what. Now, in acute pulmonary edema, which loop diuretic would you prefer? That is IV furosemide. That is IV furosemide. This is what I want you to remember from loop diuretics. So first class is carbonic anhydrase, they are acting on the carbonic anhydrase enzyme. Second one is loop diuretics, they are acting on sodium potassium 2-chloride channel in the thal. Now coming to the third class of drugs, these are thiazides. What will thiazide diuretics do? Pretty simple. This will block this sodium chloride importer. So the sodium is excreted outside along with the water. These are diuretics as well. So thiazide diuretics, easiest ones. How can you remember this? They have a name thiazide in their name. Chlorthiazide, chlorthalidone, chlorthalidone. We have one more, that is metolazone. Now where is this metolazone used? Whenever in a patient the GFR is less, I told you we can use loop diuretics. If we are using loop diuretics and if the loop diuretics are not working, and even when the GFR is less than 40 and loop diuretics are not working, you can use metolazone. All the other drugs, they can be used in hypertension. This is about the thiazide diuretics. Now coming to the fourth class of drugs, last class. Fourth class are potassium sparing diuretics. Now how will they act? Pretty simple. I told you it has to block this sodium channel. You can block this sodium channel via two ways. I told you these ENaC channels are coming only when aldosterone is acting. So you can block this aldosterone, they are known as aldosterone antagonist, or you can directly block this ENaC channels, they are known as ENaC channel blockers. Now what is this aldosterone antagonist? It is pretty popular. It is spironolactone. What about these ENaC channel blockers? These are amiloride and triamterene. That's all. These are the four classes of drugs that we have studied: carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, and potassium sparing diuretics. Now what I want you to remember in this, I want you to remember about the acute mountain sickness, about acute pulmonary edema, and then about the hypertension. These are the main uses. Now coming to the spironolactone, we'll study it in several chapters of CVS. Along with this, I also want you to remember it can be used wherever the aldosterone levels are high. This is known as primary aldosteronism, wherever aldosterone levels are high. Now amiloride can be used in something known as Liddle syndrome. What is Liddle syndrome? You study this in hypertension. Liddle syndrome is gain of function mutation of ENaC channels. That means ENaC channels will keep on working. Doesn't matter if there is aldosterone or not. That is why we are giving amiloride in Liddle syndrome. That's all. Now if you understood this much, what else you want to remember? You just have to remember the side effects of all of these. For this, I made a table which you can see here. So you can see this table. This is the revision table for entire diuretics. You can see here, first class I have written as carbonic anhydrase enzyme inhibitors. It is working on which part? It is working on the PCT. This itself is an MCQ. Whatever I am going to tell you, these are MCQs, PYQs and PYTs in all of these exams. Okay. So it acts on proximal convoluted tubule. It blocks the carbonic anhydrase enzyme. Now it will in turn block the sodium hydrogen antiporter. So if it is blocking the sodium and hydrogen, what will happen? Sodium is lost. So there is a decrease in sodium. Along with this, almost all of the diuretics will lose potassium. So it is losing potassium, and it also loses bicarbonate. Because of this, it is causing something known as metabolic acidosis. And it will also cause hyperammonemia. So it is contraindicated in liver failure. Or liver cirrhosis. This is about the carbonic anhydrase inhibitors. Now coming to the loop diuretics, where are they going to act? They are acting on the thal. Now which channel is it blocking? Sodium potassium 2-chloride channel. Now when this sodium potassium 2-chloride channel is blocked, all of these ions are lost. Now easy way to remember is loops will lose everything. It will lose almost all of the ions. So if you see here, it is losing sodium, it is losing potassium, it is also losing H+, it will also lose magnesium and calcium as well. It will lose magnesium and calcium as well. Now, if you see here, because of loss of H+, lot of loss of H+, it will cause metabolic alkalosis, and then there is loss of potassium, so it is hypokalemic, Now, coming to the thiazides, where are they going to act? It will act on DCT. Which part of DCT? This has been asked in the exam. It has been asked in the exam before. It is early DCT. Now, which channel is it blocking? It is blocking the sodium chloride importer. It also causes loss of sodium, so sodium is decreased, and it will also almost lose all of the ions. It will lose almost all of the ions except for one. It will also lose everything except calcium. It will increase the calcium in the body. So it will lose potassium, okay, it will lose H+, okay, it will also lose magnesium, but calcium is increased. So it will cause hypercalcemia. So it can be used in conditions where we want to increase the calcium. So these are drug of choice in hypertension with osteoporosis. Now, it is also causing metabolic alkalosis because H+ is lost, and there is also loss of potassium. So it is also causing hypokalemic metabolic alkalosis. Did you understand this much? Now, coming to the last one, that is potassium sparing. Where is it acting? It is acting on the cortical collecting duct. Now, there are two classes. One is aldosterone antagonist, okay. The second one is ENaC blockers. This is what it is written here. It also loses the sodium, but these are potassium sparing. So what will happen to potassium? Potassium will increase and H+ will increase. In the classes, I told you why this potassium and H+ will increase. Yes, whenever ENaC is activated, potassium and H+ will be lost because we are blocking this. Opposite will happen, that will increase the K+ and H+. This is the channel where potassium and H+ are lost whenever sodium is reabsorbed. If you block this, they will not come outside, they will stay in the body and they will increase. Yes, so I have told you all the concepts in the class. For now, we are just revising. So what is happening here? It is causing hyperkalemic because potassium is increased. Hyperkalemic metabolic acidosis. This is what I want you to understand. Why? It is given in the name itself. These are potassium sparing. Almost all the diuretics will lose potassium except for the potassium sparing diuretics. So I want you to remember it this way. There are four important classes: carbonic anhydrase, loops, thiazides, and potassium sparing. All these three will lose potassium. Only thing that is increasing potassium is last one, potassium sparing. This much you got. Now, first and the last one will cause metabolic acidosis. The middle two will cause metabolic alkalosis. This is an easy question. If they ask you which drug will cause metabolic acidosis, you know which one. But if they ask you which drug will cause hyperkalemic metabolic acidosis, I told you these two will cause metabolic acidosis, and this is potassium sparing. So this is hyperkalemic metabolic acidosis. These are potassium sparing diuretics. If they ask you hypokalemic metabolic acidosis, carbonic anhydrase inhibitors, that's all. Now, spironolactone, this will block the testosterone receptors as well, so it will cause gynecomastia and impotence. In the females, it might cause menstrual irregularities. Now, coming to the last class of drugs, this are osmotic diuretics. Osmotic diuretics can act on almost all parts of the nephron, okay, but it acts mainly on this part. Which part is this? This is descending limb of Henle. This is where osmotic diuretics are working. It is given in the name, it is causing osmosis. So what will happen? It will pull out all the water into the tubule and the water is lost. This is what is osmotic diuretic doing. Okay, good. You can see here it is working on descending limb of Henle. It is blocking H2O absorption. Okay, now Electrolyte abnormalities, anything can happen. Potassium might increase, potassium might decrease, H plus might increase, H plus might decrease. So we are not going to talk about this. But what is most important here, the example of this is mannitol. Osmotic diuretics, please remember this, very important, it is mannitol. Mannitol is drug of choice. Mannitol is drug of choice in cerebral edema as well as acute congestive glaucoma. Acute congestive glaucoma. I told you closed angle glaucoma, what is the drug of choice? CA, it is pilocarpine. Now, if a person is having a acute emergency episode of closed angle glaucoma, first you have to give IV mannitol. Once the IOP, intraocular pressure, is reduced, then you will give pilocarpine. So that's all about the diuretics. All the diuretics, you can study it in this one small table. Did you get it? Good. Now, we have talked about almost all of these parts, but we forgot about the medullary collecting duct. Yes, how can we forget this? We did not forget this. What will happen here? A hormone called ADH acts here. ADH is also known as vasopressin. ADH means antidiuretic hormone. This will reabsorb water. This is what is happening in medullary collecting duct. So there is a receptor that is known as V2 receptor. ADH will act on V2 receptor and it will cause water reabsorption in a normal person. Let us suppose a person is not secreting ADH. Then can ADH act on V2? Can it reabsorb water? No. If it cannot reabsorb water, water will be lost, and that is what is known as polyuria. Yes, this is what you see in a patient with diabetes insipidus. Did you understand? So diabetes insipidus is nothing but ADH not working. Okay. If ADH is not released from the brain, we call it central diabetes insipidus. Now, let us suppose if ADH is already released from the brain, but it is not able to act on the receptor, then we call it nephrogenic diabetes insipidus. That's all. Nephrogenic diabetes insipidus. So you understood what is diabetes insipidus as well. Now, how do you treat this? In central diabetes insipidus, we don't have ADH. So you give ADH. Now, there is a drug called desmopressin. It acts mainly on V2 receptor. So, desmopressin is the drug of choice in central diabetes insipidus. So, in central diabetes insipidus, what is happening? There is no ADH itself. So, we will give ADH from outside. So, there is a drug called desmopressin which works exclusively on V2 receptors. V2 receptors are present in several areas, but when it acts on the V2 receptor of medullary collecting duct, it will cause reabsorption of water. So it is used in central diabetes insipidus. It can also be used in nocturnal enuresis. What do you mean by nocturnal enuresis? That means a kid urinates at the night time. So if the kid is urinating at the night time, if you give desmopressin, what will happen? The water will be reabsorbed and urine formation will be decreased. That is why it is also drug of choice in nocturnal enuresis. Now, if you understood this much, we will see about the vasopressin related drugs. Recombinant vasopressins, we have two, terlipressin and desmopressin. Terlipressin acts mainly on V1 receptor. V1 receptor is present on blood vessels. It will cause what? Vasoconstriction. So that is why it is drug of choice for esophageal variceal bleeding. Why? What do you mean by varices? That is vasodilation. If you cause vasoconstriction, can you decrease this bleeding? Yes. That is why we give terlipressin, because it acts mainly on V1 receptor. Next is desmopressin. It acts mainly on V2 receptor. That is why it is drug of choice for central diabetes insipidus, nocturnal enuresis, and it is also drug of choice for von Willebrand disease and hemophilia A. Von Willebrand disease and hemophilia A. This is what I want you to remember. Okay. Now, the most important thing in psychiatry is they might ask you what is the treatment of choice for nocturnal enuresis. Drug of choice is desmopressin, but treatment of choice is bed alarm therapy. Bed alarm therapy. Did you understand? Bed alarm therapy. Now, you have seen the ADH analogs. What about ADH antagonist or vasopressin antagonist? If it blocks the V2 receptor, what might happen? Now, I've told you about a condition that is diabetes insipidus. Let us suppose if there is too much of ADH, what might happen? That is what is known as SIADH. lot of water is being reabsorbed. Now what can you do? You cannot decrease the ADH level, but you can block the receptor that it is working on. That is what is vasopressin antagonist. These are known as vaptans. Vaptans means vasopressin antagonist. Vasopressin antagonist. Tolvaptan, mozavaptan, conivaptan. Conivaptan is IV. The other ones are oral. These can be used in SIADH. This finishes your renal system. Now before going, I just want you to remember three things. This one you already know, central diabetes insipidus. What is the drug of choice? That is desmopressin. Okay. Now next, nephrogenic diabetes insipidus. What is the drug of choice? The drug of choice is thiazide diuretic. Now lithium can also induce diabetes insipidus. Lithium induced diabetes insipidus. What is the drug of choice? Amiloride. Amiloride is also drug of choice in Liddle syndrome, if you remember. Now how can you remember all of this? Central desmopressin, okay, you know. Lithium induced, you can see here amiloride, LO, yes, lithium, so Li, lithium. So this is how you can remember. Now coming to nephrogenic diabetes insipidus, where is the receptor present? It is present on the tubules, collecting ducts. Yes, it is present on collecting duct, but try to remember it is present on tubes, isn't it? Collecting duct means tubes. So T for T, thiazides. This is how you can remember all the three diabetes insipidus and their drugs that can be used respectively. Now if you understood this much, again revise 1 minute, try to revise the entire diuretics and also see the vasopressin related drugs. Next we will start with the general pharmacology. Okay. So I hope you have revised the renal system. Now we'll start with the general pharmacology. We'll try to do all the questions at the end since these are smaller chapters. Okay. So starting with the pharmacokinetics and dynamics. We've already done this in the discussion, if you remember. Pharmacokinetics and dynamics. Kinetics are movement of the drug, like absorption, distribution, metabolism and excretion. Now what about the dynamics? Drug is binding to the receptor, receptor is causing the effect. That is what we have studied in the introduction, if you remember. So I told you we are going to just build up on the concepts of these. So starting with the pharmacokinetics, what is the first thing we have studied? This is absorption. I've already told you absorption, if the absorption has to happen, the drug should be lipid soluble or water soluble. It should be lipid soluble. This is what I told you. Yes, the lipid soluble drugs are absorbed. They can cross the membrane. Now, which drugs are lipid soluble? Which drugs are lipid soluble? Try to understand. If you remember in the ANS chapter, I told you tertiary amines and quaternary amines. I told you quaternary amines, quarter mixes in water, so it is water soluble. Tertiary amines are lipid soluble. This is what I told you. Now, how do you write tertiary amines? Let us suppose one example is NH3. What about quaternary amines? NH4 plus. You can see here plus. This is an ionized form. So ionized forms are water soluble and non-ionized forms are lipid soluble. Non-ionized forms are lipid soluble. So the drug has to be non-ionized form to be lipid soluble. This is what is important for absorption. This is one factor. Okay. Now we will see the factors that are affecting the absorption. Before that, we'll try to see most of the drugs are absorbed by simple diffusion. That is what we have seen in the beginning as well. But what is absorption? It is the movement of drug from the site of administration into the systemic circulation. That also I told you. Now, let us suppose I am giving a drug and this drug is acidic drug. Let us suppose I am giving an acidic drug. This has come, it is going into the stomach, then it will go into the small intestine. So we will see an acid drug when it goes into the stomach. The acid is, the medium of stomach is acid. So acid and acid, there will be no reaction. So it will be in non-ionized form. I told you non-ionized form is lipid soluble. So lipid soluble drug can cross the membrane and be absorbed. So it will cross membrane. This is what I want you to understand. So if the drug has to cross the membrane, it has to be in unionized or non-ionized form. Now the same acidic drug now will come into the small intestine. What is the medium of small intestine? It is basic. Now acid and base will combine together, it will form ionized form, so it will become water soluble. Now it will not cross the membrane. It will not cross the membrane. If I give a basic drug, the basic drug will first go into the stomach, so it is acid. Medium of stomach is acid, isn't it? So basic drug and acidic medium, when they combine together, it will again cause ionized form, so this is water soluble and it will not cross the membrane. If this basic drug goes into the intestine, it is alkaline medium, so this is basic medium and it will become non-ionized. It will become lipid soluble, it will cross membrane, that's all. So what is important for absorption? It is the non-ionized form. When the drug is in non-ionized form, it will cross the membrane. So this is when absorption happens, when these are in non-ionized form. Now the MCQs, let us see. Acidic drugs are maximally unionized in. Acidic drugs are maximally unionized in which medium? Acid medium or basic medium? It should not react. No, it is an acid medium. So it should be in a stomach. Okay. So if the acidic drugs are maximally unionized in stomach, acidic drugs are maximally absorbed in which part? Stomach or small intestine? Stomach or small intestine? What is it? Answer. Sir, obviously it is maximally unionized in stomach, so it should be absorbed from the stomach. No. The answer is duodenum. This is what I told you in the beginning of the class. I told you most of the drugs are absorbed from the duodenum. Doesn't matter. The solubility, the acidity, doesn't matter. It will always be absorbed from duodenum. Why? Because yes, absorption is dependent on the form, the solubility, lipid and water solubility, but absorption is mainly dependent on the surface area. Most important factor is surface area. Since the surface area of duodenum is more, most of the drugs are absorbed in duodenum. Doesn't matter whether it is an acidic drug or basic drug. This is what I want you to understand. That is why I told you so much of this. Now, if you understood this, what are the factors that is decreasing the absorption? Let us suppose a person is having diarrhea. Will the drug stay in the stomach and the intestine for a longer period of time? No, it will stay for a shorter period of time. So diarrhea will decrease the absorption. If a person is having shorter bowel, let us suppose he has been operated and some part of the bowel has been taken out. Now what will happen here? The absorption will be decreased because the surface area is decreased. These are the factors that is decreasing the absorption. Good. Now how do you know this ionization? I told you that if the drug is in non-ionized form, it will be absorbed. Now how can you know if the drug is in ionized form or non-ionized form? If it is in ionized form, how much of it is in ionized and how much of it is in non-ionized? That is why we have an equation that is known as Henderson-Hasselbalch equation. Now I don't want you to remember the equation, but I want you to remember something that is known as pKa. pKa comes from this Henderson-Hasselbalch equation. What does this pKa says? pKa is the pH at which 50% of drug is in ionized form, okay, and 50% of the drug is in non-ionized form. So 50% is ionized and other 50% is non-ionized. It is what is pKa. This is what has been asked in the exam so many times. Now if you want to go one step further and if you want to remember, if pH minus pKa is equal to 1, one form will become 90%, other form will become 10%. Now if it becomes 2, the other form will become, one form will become 99 and other form will become 1%. Why? Because this is logarithm. This is logarithm. When you see that equation, you will understand. Okay. So this is the calculations, but I just wanted to remember what is pKa. If you understood this much, next we will talk about a concept that is known as bioavailability. What do you mean by bioavailability? See, bioavailability means the amount of drug that is coming into the systemic circulation unchanged. It is the amount of drug that is reaching the systemic circulation unchanged is what is bioavailability. What do I mean by this? So let us see what is this bioavailability. If I am giving a 10 milligram drug orally, it goes into the mouth, then again pharynx, esophagus, stomach, duodenum. I told you most of the drug is absorbed from duodenum, then stomach. Let us suppose from duodenum and stomach the drug is being absorbed. Now, how much is absorbed? Let me tell you. Let us suppose 8 milligram of this drug is absorbed and 2 milligram is lost. Okay. Now, this 8 milligram, which vein will go into the liver? This is known as portal vein. So, the portal vein will take 8 milligram of drug into the liver. Now, what will liver do? Liver will also take some of the drug with itself. So, let us suppose liver is taking 2 milligram again. 2 milligram again. This is known as first pass metabolism. This is known as first pass metabolism. If you remember, I told you before, there is absorption, distribution, and then there is metabolism. Now, what I am saying is, even before absorption has happened, the drug is passing through the liver for the first time. That is why this is known as first pass metabolism. So, first pass metabolism and metabolism are completely different. So, let us suppose if 2 milligram is taken up by the liver. Now, how much will reach the inferior vena cava from the liver? How much will reach? 6 milligram. So, I gave 10 milligram and 6 milligram has come. What is the bioavailability? This is the bioavailability. Did you understand? So, if you understood this much, what could be the factors that are affecting the bioavailability? If there is more absorption, if more amount of drug is absorbed, bioavailability will be more, obviously. Yes. So, that is why bioavailability is directly proportional to absorption. Now, if more drug is utilized, in the liver, let us suppose the liver is taking 5 mg from 8 milligram, how much will go? 3 milligram. Did you understand? If first pass metabolism is more, bioavailability will be decreased. That is why bioavailability is inversely proportional to the first pass metabolism. If first pass metabolism increases, bioavailability decreases. This is what I want you to remember from the bioavailability. These are the factors that are affecting the bioavailability. Now, coming to the drugs with high first pass metabolism, you have to know this. These are nitrates. No, seriously, nitrates have large first pass metabolism. That is the mnemonic itself. Seriously means salbutamol, nitrates means nitrates, hydrocot means have, nitrates have large lignocaine first pass metabolism, first pass P for propranolol, metabolism for morphine. Seriously is salbutamol, nitrates for nitrates. I just want you to remember nitrates. Nitrates have large first pass metabolism. So, some amount of drug is going into the absorption. That is the reason why we give the drug in a sublingual route. Sublingual route. When you give it sublingually, you have seen patients taking this tablet under the tongue. No, this will bypass the first pass metabolism. That is why sublingual route is preferred. Now, if you understood this much, next there is a concept that is known as plasma concentration time graph. Really important, has been asked in exam so many times. Let me make it simple for you. Let us suppose this is plasma concentration and this is time. Okay, when you are giving the drug, what will happen to the drug in the plasma? When you give the drug, it will slowly start to increase first. It will reach a peak plasma concentration, and after some time this will be metabolized and excreted. Yes, this is the graph that is there. That's all. So, this peak plasma concentration is what is known as Cmax. So, Cmax is maximum plasma concentration. Now, how much time does it take to reach this maximum plasma concentration is known as Tmax. That is what is Tmax. It is the time taken to reach Cmax. Did you understand this much? That's all. That is Cmax and Tmax. Now, the area that is present under this entire curve is known as bioavailability. Bioavailability. So area under curve is known as bioavailability. That's what. Now they'll ask you one more question. Which of these represents the rate of absorption? Rate of absorption. Rate means speed, no. Which one will tell you if the drug is absorbing faster or slower? Which one? Cmax, Tmax or AUC? If you use common sense, it is Tmax because it is telling you the time, no. It will tell you the time in which drug is being absorbed. If it is absorbed in 5 minutes and if the drug is absorbed in 10 minutes, 5 and 10, which one is faster? 5 is faster. That is why Tmax will tell you the rate of absorption. If you cannot remember this much, T and T, rate mein T hai, Tmax mein T hai, so T and T, rate of absorption Tmax. Please remember this. Bioavailability AUC, maximum plasma concentration Cmax. That's all about this graph. So once you finish the absorption, next I told you there is distribution. What is distribution? From the systemic circulation, drug is distributed to various organs of the body. That is what I told you. When it goes to the organs that we want, it gives the effect. When it goes to the other organs, that we don't want its effect on, it will cause side effects. So what did I tell you before? Distribution is the reason why we have effects. Now what I am telling you is distribution is the reason why we have both effects and side effects as well. So distribution is really important for us. Now what are the factors that are affecting this distribution? Again, these are same: fat content, lipid solubility and the tissue binding. Let us suppose if the fat content is more and if the drug is lipid soluble, obviously lipid soluble drugs will stay more in the fat content. Yes. So both of these are directly proportional. Okay. If the drug is lipid soluble, it will be absorbed more. If there is more fat content, lipid soluble drugs will stay in the fat content. So that is why volume of distribution is directly proportional to this. Now tissue binding. Tissue binding means drug is going to a tissue and binding inside it. If the drug is staying in the tissue for a longer period of time, that means volume of distribution is more. So it is also directly proportional. Next comes to the plasma protein binding. This is what is important. See, let us suppose this is systemic circulation and it has to go into an organ to cause effect. That is what is distribution I told you. Okay. That is what is distribution I told you. Now, inside the plasma we have proteins. If the drug is bound to this protein, can this drug cross the membrane and go into the tissue? No, proteins cannot cross the membrane. Drug also cannot cross the membrane. So it will stay back. That means if plasma protein binding is increased, distribution is decreased. So this is inversely proportional. Fat content, lipid solubility and the tissue binding are directly proportional. Plasma protein binding is inversely proportional. This is what I want you to understand. Now, coming to the some drugs which have high volume of distribution and high ppb. If there is high volume of distribution, that means the drug is in tissues. Okay. So the drug is in the tissues. If the drug has high plasma protein binding, the drug is in the blood vessels. Okay, good. Now, what would be the problem if the patient has taken a drug with high ABD or high ppb? What could be the problem? Let me tell you. Let us suppose a person is having a drug toxicity. How do you treat it? Most of the times when you don't have antidotes, you will do dialysis. For dialysis to happen, the drug has to be in the blood and then it goes into dialysis machine and it has to be filtered. This is how dialysis works. Now, if the patient has taken a drug with high ABD, the drug is already in the tissues. It is not in the plasma, so it cannot be filtered through dialysis machine. Okay. If the drug has high plasma protein binding, the drug is bound to the plasma protein. Now, can it be filtered into the dialysis machine? No, it will stay along with the protein. So the drug cannot be filtered. Did you understand this much? That is why you cannot do dialysis in these drugs. So you avoid dialysis. That is the mnemonic itself. A for A, amphetamines, V, verapamil, O, opioids, and OP, I is imipramine, D for digoxin, and dialysis for diazepam. These are the drugs where you avoid dialysis. Okay. Now, coming to the metabolism. We have talked about the absorption, distribution, now metabolism. What is the aim of metabolism? If you remember, we are converting lipid soluble drugs into water soluble drugs. Yes, this is how we are doing it. What does it mean by water soluble? I told you water soluble means it has to be in ionized form. So that is what we will do. There are two phases. First phase will break the drug. Second phase, there will be a conjugation reaction. What will this conjugation reaction do? We will add a negatively charged molecule to this pieces of drugs, negatively charged molecules. So these have become ionized. That means they have become water soluble. That means they will be excreted. That's all. Did you understand? So this is what we are doing in metabolism. First step, they are breaking the drug into smaller pieces. Now, to these smaller pieces, we are adding a conjugate that is negatively charged, so it will become water soluble. That is what is happening. Now, conjugation means adding something. What is the most commonly added conjugate group? It is glucuronidyl group. That is why this reaction is known as glucuronidation. Or you can also add methyl group, methylation, sulfation. You can see here methylation, sulfation, acetylation, glutathionation, glucuronidation. So if you are adding anything, those are phase 2 reactions. Easy to remember: glucuronidation, glutathionation, sulfation, acetylation, methylation. Now, when you come to the phase 1 I told you it is breakdown. So you can see here cyclization, hydrolysis, deamination, oxidation. Oxidation means removal of hydrogen. Yes, reduction means removal of oxygen. So all these things we are breaking something. So oxidation, reduction, cyclization, all of these are phase 1. So this is how you can easily remember. Now, what is important? Almost all of the phase 1 reactions and the glucuronidation reaction, all of this is happening with the help of microsomal enzymes. Other things are happening via non-microsomal enzymes. Now, why are these microsomal enzymes important? These are inducible enzymes. Microsomal are inducible. That means you can either increase or decrease these enzymes. So, if you see, almost all of the drugs are metabolized by microsomal enzymes. Why? Phase 1 happens to all the drugs. Yes. Phase 2, you see here glucuronidation. Glucuronidation is the most common reaction. So I am seeing microsomal enzymes are doing this glucuronidation. So almost all the reactions of almost all the drugs are happening via microsomal enzymes. Microsomal enzymes are inducible. Now, what do you mean by inducible? Let us suppose, we'll write it somewhere else. Yes, we'll write it here. If we induce enzymes will increase in number. If enzymes are increased, it will cause more metabolism. So, what will happen to the effect? The drug effect will decrease and it will cause drug failure. Now, if we inhibit these enzymes, these are known as enzyme inhibitors. What will happen? Enzymes will decrease. If there are decreased enzymes, will metabolism happen? No, there is decrease in metabolism. So what will happen to the drug concentration? Drug concentration will increase, effect will increase, and if the effect increases too much, it will cause toxicity. So inducers are causing failure, inhibitors are causing toxicity. This is what I want you to understand. Now, which are these microsomal enzymes? These are known as CYP enzymes. You might have studied most common CYP is CYP3A4. So now we will see there are some drugs which will induce these enzymes and inhibit these enzymes. Now, there is a list that you need to know, but in the class I told you with the help of a story to remember all of these drugs. Now, since the time doesn't permit, I cannot tell you the entire story, but I'll tell you the gist of it. I told you there are a group of people who are traveling, and because of the bad GPS, it has caused irritation. So I have told you that bad GPS means crap GPS induces irritation. This is what I told you in the story, yes, if you remember. So CRAPGPS, C for carbamazepine, R for rifampicin, A for alcohol, P for phenytoin, G for griseofulvin, P for phenobarbital, S for smoking. You need to remember these. Then I told you, whenever there is irritation, the other friend tries to inhibit this irritation or decrease this inhibition by giving coke, quick coke. I also told you he will give alcohol, grapefruit juice, vitamin C, all of these, but at least for now, remember quick coke. Quick means quinidine, coke means clarithromycin, omeprazole, ketoconazole, erythromycin. At least remember this much. Quick coke will inhibit the irritation. These are enzyme inhibitors I want you to remember. Okay, so clarithromycin, omeprazole, ketoconazole, erythromycin and quinidine. If you understood this much, now these enzymes can be induced or inhibited by these drugs. Because of this, it will cause effects on other drugs. These are known as drug interactions, very important in the exams. There are many, but I will tell you the most commonly asked drug interactions here. In the exam, they always ask about rifampicin. Yes, person is taking ATT and the person is using OCP. What will happen? Yes, rifampicin is an enzyme inducer. So what will happen to the OCP? OCP is also metabolized by CYP. So this will increase the metabolism of OCP and it will cause OCP failure. This is what I want you to understand. Okay. Next is erythromycin. Erythromycin is a enzyme inhibitor. So in the exam, generally they ask you about erythromycin and theophylline. So when erythromycin is given, this will inhibit the enzymes that are metabolizing the theophylline and it will cause theophylline toxicity. Same thing with clarithromycin. It is enzyme inhibitor. So when it is given along with statins, it will increase the toxicity of statins and it will cause statin myopathy. These are three clinical cases that are usually asked in the exam. Now, we'll talk about the drugs that are undergoing acetylation. I told you, most of the drugs in the phase 2, they will undergo glucuronidation, but there are some drugs that are undergoing acetylation. What is so important about these drugs? There is something very important. Let us try to see. There are known as SHIP drugs which will undergo acetylation. What are these SHIP drugs? S for sulfonamides, H for hydralazine, I for isoniazid, P for procanamide, D for dapsone. Now, all these drugs, instead of glucuronidation, they will undergo acetylation. That is good. Okay. Now, acetylation is done by an enzyme known as NAT enzyme. These enzymes are slow in some people, fast in some people. Yes, so we can call them slow acetylators, fast acetylators. How can you remember? See, if you see Western culture, we call it as fast culture now. So you can easily remember fast acetylators are Americans. So these drugs will be acetylated fastly and metabolized. Now, slow. Slow means Indians. 2/3 of Indians are slow acetylators. If the metabolism is slow, what will happen? These drugs will cause drug-induced erythematosus, drug-induced lupus erythematosus. So, SHIP drugs are causing drug-induced erythematosus in slow acetylators. This is what I want you to understand. With this, you completed the metabolism. So, we have finished with the metabolism. I want you to remember the inducers and inhibitors in that. Now, coming to the excretion. How does excretion happen? All of you know there is first filtration of the substances and there is reabsorption and then there is secretion. These are the processes, but I want you to focus mainly on the reabsorption. I told you most of the filtrate is reabsorbed. We have seen in the renal system 99% of the sodium is reabsorbed. Here 99% of GFR is reabsorbed. Now, for absorption to happen, I told you it should be lipid soluble drugs. So, lipid soluble drugs are reabsorbed, water soluble drugs are excreted, water soluble drugs are excreted. So, let us suppose if there is a drug poisoning, if there is any drug poisoning, if you want to treat this poisoning, you will tell me hemodialysis. Okay, let it be. Before that, if there is any drug poisoning, how can you treat? If you make the drug water soluble, will it be excreted in the urine and the concentration will be decreased? Yes or no? Yes. How can you make the drug water soluble? That is what we are going to see. We have two kinds of drugs. Yes, acidic drugs and basic drug. Examples of acidic drugs, these are aspirin, methotrexate, barbiturates. Remember these. If there is any of this drug poisoning, what can you do? What can you do? Now, these are acidic drugs. When they come into the PCT, how can you make it water soluble? I told you, water soluble means you have to make them ionized. So, this is acid. Now, if you make the urine alkaline, acid plus alkaline will form what? Ions. Ionized forms, water soluble. These drugs will be excreted, so that is the treatment. So you're making the urine alkaline. So this is what is known as forced alkaline diuresis. Now coming to the basic drugs. Basic drugs are anything with name ene. If it is ending with ene, I-N-E, these drugs are basic drugs. One example I've given is amphetamine. Now, if it is a basic drug, how can you make it water soluble? You have to make the urine acidic. So, that is what is known as forced acidic diuresis. That's all. Acid plus base, it will form ionized forms and it is water soluble and it will be excreted. So, how can you make the urine alkaline? You already know this by giving bicarbonate, that is sodium bicarbonate, because it is alkaline. Now, acidic, it is by ammonium chloride. If you cannot remember this, you can see in the ammonium chloride, H and Cl is present. So, HCl is acidic. So, forced acidic diuresis is done by ammonium chloride. This is what I want you to remember. Now, if you understood this much, next is T-half. T-half is the time taken by the drug to become 50% in plasma concentration. So, how much time it takes for the drug to become 50% is what is known as T-half. There is a formula. If you want to remember this, try to understand with the basics. T-half is directly proportional to volume of distribution. Why? If the volume of distribution is more, the drug will stay in the tissues for a long period of time. If it is staying in the tissues for a long period of time, it will take longer time for the drug to become half because it is not being excreted fastly, isn't it? So, if VD increases, T-half will increase. Yes. Now, what about clearance? If clearance increases, what happens to T-half? If the drug is excreted rapidly, so it will reach its 50% faster, no? Did you understand? So the time taken by the drug to become 50% will decrease. So if the clearance is more, T-half will decrease. So T-half is inversely proportional to clearance. That is why we can write T-half is equal to VD by CL. There is a constant 0.693. This is what I want you to understand. Then there is formulas of rate of elimination, clearance and plasma concentration. But what is more important here is the loading dose and the maintenance dose. Yes, loading dose and the maintenance dose. What are they dependent on? This will be asked in the exam. Now, loading dose is equal to AVD into plasma concentration. Loading dose means, see, let us suppose you want the drug to stay in the plasma. This is blood vessel. You want certain amount of drug to stay in the plasma. Okay. Now, in the distribution, what will happen? the drug will go into various tissues. So in the loading dose, if you want the drug to stay in the blood vessels, it has to fill up all the tissues that it can. That is why you can remember it in a simpler way, that loading dose is directly proportional or is directly dependent on volume of distribution. Now coming to the maintenance dose. Maintenance dose is equal to clearance into plasma concentration. Let us suppose I have given 100 mg of drug and 50 mg of drug is eliminated. Now how can I maintain this 100 mg? I have to give back this 50 mg. So I am giving how much ever is excreted. So that is why it is dependent on clearance. This is easy to remember. Maintenance dose is dependent on clearance. Loading dose is dependent on volume of distribution. So you can see here volume of distribution and loading dose. Yes, this is how you can remember them. Maintenance dose is equal to clearance into plasma concentration. Okay, good. Now we will see the kinetics of drug elimination. How the drugs are being eliminated, what are its kinetics. Yes, we have two kinds of kinetics. First order kinetics and zero order kinetics. I mean, we will see here. First order means constant fraction of drug is eliminated. FRF, constant fraction of drug is being eliminated per hour. In zero hour, constant amount. Constant amount. So what will happen to T half and clearance? Let us suppose if we increase the dose, even if we increase the dose, constant amount will be excreted. Constant amount will be excreted. That is why T half will remain constant and clearance will also remain constant. How? Let us take an example. Let us suppose there is a 100 mg drug and 50 milligram is excreted or cleared. Yes, how much will remain? 50 milligram in 1 hour. In 1 hour. So this is what is T half. No, exactly half is removed. So this is what is T half. Now if I increase the dose, let us suppose I made it 200. Now also I am saying 50% will be excreted. Why? Because it is constant fraction of drug. 200 will become 100 in 1 hour. So what happened? What happened to the T half? T half is constant. How much is cleared? That is also constant. Now coming to the zero order kinetics, I am telling you constant amount of drug is eliminated. Let us suppose 100 mg is becoming 50 mg in 1 hour. Now I increase the dose, I made it to 200 milligram. Now what I am saying is constant amount, only 50 milligram can be excreted here, so it will become 150 mg. So in the next 1 hour, another 50 will be excreted and it will become 100 mg. So what happened to the T half? What happened to the T half? T half is increased. So if you increase the dose, T half will increase. Why T half is increased? Because clearance is reduced. This is what I want you to remember for first and zero order kinetics. That's all. If you want to remember one single thing, F for F, constant fraction. Now why is this important? See, almost all of the drugs will follow the first order kinetics. That means kidney is removing the drug really well. Almost all of the drugs follow the first order kinetics in normal therapeutic doses. But if you give the drug in higher dosages, the kidney will get tired and it will not be able to remove as much as possible because enzymes are used up. Okay. Did you understand this much? So all the drugs will follow first order kinetics, but when these drugs are given in higher plasma concentrations, they will follow the zero order kinetics. But there are some drugs which will follow zero order kinetics even in normal plasma concentration. This is what is important. Yes, especially therapeutic plasma concentration. So let us suppose even in therapeutic plasma concentration, there are some drugs that are following this zero order. What are those drugs? These are alcohol, theophylline, phenytoin, heparin and warfarin. Really important. Heparin and warfarin. These are the drugs that are following zero order kinetics even in therapeutic doses. Alcohol will follow the first order kinetics anywhere. So this is the true zero order. True zero order. Any dose alcohol is zero order. Rest all is first order. When you increase the dose, they will become zero order. But there are some drugs which will have zero order even in therapeutic doses. Those are these. That's all. Now, coming to pharmacodynamics, I already told you, drug is binding to receptor to cause effect. That is what is pharmacodynamics. Yes. Now, the tendency with which the drug binds to receptor is known as affinity. Tendency with which drug binds to receptor is what is known as affinity. What about efficacy? The effect that is seen after binding to the receptor is known as efficacy. What is potency? The dose that is required to produce certain effect. That's all. So I told you in the beginning itself, if you know the basics, you understand everything. Drug binding to receptor is affinity, receptor causing effect is efficacy, and the dose that is required to produce this effect is potency. That's all in pharmacodynamics. Now, classification of drugs. So drugs are divided into two. What are they? Agonist, antagonist. Agonist, antagonist. This is what we have told in the beginning in the basic terms. Now we will see it in detail. Now, let us suppose this is the effect. +1 is the maximum effect, -1 is the minimum effect, 0 is in between. So, if the drug has maximal effect, that means its intrinsic efficacy is +1, that is known as full agonist. If the drug has submaximal effect means it can be anywhere between 0 to 1. That is what is known as partial agonist. Now concentrate very, very carefully. See, antagonist means its effect is 0, not reduced, its effect is 0. I am repeating it again, effect is 0. That is what is antagonist. Effect is 0. Now, coming to inverse agonist, its effect is reduced, that is -1. That's all. Effect is 0, antagonist. Now, there are different types of antagonists. What are they? You can see here, physical antagonism, chemical, physiological, and pharmacological. What do you mean by physical? The drug physically binds to the target to prevent the effect. Let us suppose you give activated charcoal in poisonings, that is physical. Now, what about chemical? It binds to the drug chemically. That's all. You use protamine sulfate, yes or no? Protamine sulfate for heparin. This is one example. It neutralizes the heparin. Physiological antagonism means opposite effect by acting on different receptor. Let us suppose in allergy, H1 receptor will cause bronchoconstriction. Now, if you see in anaphylactic shock, what is the drug you give? You give adrenaline. This is what we talked. Adrenaline will act on beta 2 to cause bronchodilation. So, this is a physiological antagonism. Now, coming to pharmacological antagonism, this is what is important. We have two, competitive and non-competitive. Competitive and non-competitive, this you will study in biochemistry also. We will see it in a simple way. Okay. So, let us suppose this is an enzyme. Okay, and this is the active site of the enzyme. So, substrate will usually bind to this active site and will cause the effect. Now, if we give a drug that looks exactly like this substrate, it will compete with this substrate for the active site. That is what is known as competitive antagonism. That means substrate and inhibitor are similar and they bind to the same site Now, inhibitor binds at the active site. So, there will be what? Inhibition. But if you increase the dose, you can get the normal effect. I mean, if you increase the substrate, it can push the inhibitor away. This is what we have studied. So the dose is given as Km. In the graphs you will see there is Km is dose and effect is Vm. So if you are getting the normal effect by increasing the dose, Vm is constant. That's all. Coming to the non-competitive. Non-competitive means, see, substrate you can see here. Inhibitor has a different structure and shape. It has a different shape. So, can this bind to this active site? No, it binds to the allosteric site. Unfortunately, when it binds to the allosteric site, it will change the shape of active site and the effect is reduced forever. That means Vm is decreased. Did you understand? But Km is constant. Inhibitor binds at allosteric site. This is what they ask you to remember in a way. Yes, they say competition. Competition means when you are running, kilometers will increase, Km increases. This is how simply you can remember. Vm is constant here. In here, it is exactly opposite for the non-competitive. So, non-competitive means it will bind to the receptor irreversibly. That means even if it goes away, the effect is irreversible because it has changed the shape of the active site. Okay, this is about the competitive and non-competitive. And in this they will ask questions about the Michaelis-Menten graph and stuff you will study in biochemistry. Please try to understand in a simple words. Let us suppose if the graph is crossing here, if the graph is crossing here, that means you can remember it as two swords that are crossing. That is what you see in competition. No, this is competitive. Now in this graph you see here, if it is not crossing, that is non-competitive. There is no competition between them. This is what I want you to remember. Now coming to the dose response curves. You see here, this is log dose. You have quantal DRC and graded DRC. Graded means it is done in a single person and you can actually grade the effect. Let us suppose we will take this as response. This is 5 milligram dose, this is 10 milligram dose, this is 15 milligram dose. Response is 20, 40, 60, 80, 100. Okay. So what I am saying is, if I give a 5 milligram tablet, it has reduced the BP by 40 millimeter of Hg in one person. Yes, now I have given a drug B. 10 milligram, it is reducing up to 80. Now I have given a drug C, 15 milligram, it is reducing up to 60. Now you tell me, which drug is more effective? Very easy, no? Efficacy. Which drug is more effective? Obviously the drug that is decreasing 80 millimeters, so it is B. Next C. Next A. So efficacy is directly dependent on height. Okay. Next they will ask about potency. Which drug is more potent? This is where people might get confused. Which drug is more potent, A, B or C? See, potency means the relative dose required to produce a certain effect. Let us take the certain effect as 40. How much dose is required to reduce 40 millimeter mercury of BP? How much is required? You see here, for drug A only 5, for drug B 10, for drug C 15. So which is most potent, most powerful? It is drug A. So A, B and C. So this is dependent on left-sidedness. So whatever is on the left side of the graph, that is most potent. Whatever is on the height, which one is on the top, that is the most efficacious. That's all. Efficacy and potency you can remember like this. Now quantal DRC is done in population. You can see here, this is what is known as 50% of population. So I call this ED50. I call this ED50. ED50 means effective dose. That means the dose that is required to produce effect in 50% of population. So this is effect. To see effect in 50% of population, what is the dose? That is ED50. Now, the dose that is required to see toxicity in 50% of people is TD50. The dose that is required to produce lethality in 50% of population is LD50. So, LD50 is generally not measured in humans, this is only seen in animals. This is only seen in animals. So, from this you can understand the therapeutic range, index and window. How will you know? What is the formula? It is TD50 by ED50. This is the formula in humans. If let us suppose in animals, it is LD50 by ED50, because it is not ethical to kill humans, no. We cannot check lethal dose. Lethality means death. Lethality means death. Now, why this is important? See, therapeutic range means the dose should be in such a way that there should be effect, but it should not cause side effects. So, this is the safe window. This is the safe window that we want in a drug. This is what we call it as therapeutic index. Therapeutic index. So, if a drug has low therapeutic index, it will cause toxicity. Low therapeutic index drug will cause toxicity. This is what I want you to understand. Let us suppose I am saying therapeutic drug, therapeutic index of a drug is from 500 milligram to 1000 milligram. So, I can give 600 milligram, 700 milligram, 800 milligram, 900 milligram, good. Now, if I say the drug therapeutic index is 10 milligram to 12 milligram. Let us suppose a person has taken 10 milligram tablet and he forgot and he has taken one more. So, it will become 20 milligram. He will go into toxicity. So, low therapeutic index will cause toxicity. These are the drugs which are having low therapeutic index. Now, if you understood this much, finally we are going into the clinical trials. In this we have something known as scheduled drugs. Scheduled drugs means you might have seen when doctor writes you a prescription, you go and buy a drug. When you turn the drug behind, you will see it was written Schedule H. So, Schedule H means these are prescription drugs. If it is written H1, these are antibiotics. There are something known as Schedule X. This is only for narcotic and psychotic drugs. So, H and X done. Schedule G is given only under medical supervision. So, G, H and X, that's all. Now, coming to the OTC drugs, these are given over the counter. That means you don't need any kind of prescription. Orphan drugs. Orphan drugs means these are drugs used for very rare conditions. Rare conditions. Example is a drug called Digibind, which is an antidote for digoxin. See, digoxin itself is not used commonly nowadays. Its indication has reduced drastically. So, digoxin itself is not being used. If this digoxin causes digoxin toxicity, we have to use Digibind. So, you see it is very rare. So, this is an orphan drug. Now, scheduled drugs are done. Coming to the pregnancy drug categories. Pregnancy drug categories. Now, some drugs are safe in pregnancy, some drugs are not safe. Why? Because these will cause teratogenicity. Now, there are some drugs which are causing teratogenicity in humans. These are known as category D and X. Category D and X. Category X, as it is written, it should never be given in pregnancy. Never given in pregnancy. Okay. Example is thalidomide. In the olden days, people used thalidomide for morning sickness and it has caused something known as phocomelia. Category D is also causing teratogenicity, but it can be used when benefit is more than the risk. When benefit is more than the risk. Category A, B and C are safe to be used. That's all. What will the examiner try to do? They will try to confuse you between Schedule X and Category X. Please don't get confused. Category X is for pregnancy categories. Yes, Schedule X is for narcotic drugs. Please try to understand this subtle difference. Schedule X and Category X are not same. Next, coming to the counterfeit drugs. Spurious drug. Spurious drug means fake drug. They will say this drug is paracetamol, but when you check it, there is no paracetamol in it. Misbranded drugs, that means the labeling is wrong. It might be about the expiry date, it might be about the directions of the use. Yes, there is wrong labeling, that is what is misbranded drugs. Adulterated drugs means some unwanted substances mixed in the drug. That's all. Now, finally coming to the drug development. In drug development, there are 4 phases. Phase 1, phase 2, phase 3, phase 4. Now, phase 1, what do you check? You check almost everything here. You check for pharmacokinetics, you check for pharmacodynamics as well. See, you check for maximum tolerable dose, what is the toxicity, and you can check for pharmacokinetics and dynamics except for efficacy. See, can you do all of this? Can you check for toxicity and all of this in patients? No, you cannot. No, because the patient might get even more sick. So that is why it is done in healthy people. Okay. Now, in phase 2, we will determine the efficacy. In phase 3, we will confirm the efficacy. After confirming the efficacy, the drug is approved. The drug is gone for approval. And once it is in the market, we will do phase 4, that is long-term adverse reactions. So, you will check for long-term adverse reactions. Yes. So, phase 1 is done in healthy people, rest all are done in patients. Obviously, how will you check for efficacy? In patients only. Can you check for efficacy in healthy people? No. That is why phase 1 mein efficacy check nahi karta. Did you understand this much? Good. Now, coming in, how many people do we do it? See, in Goodman and Gilman, it is clearly written that phase 1 is done in a few hundred people. Okay. Phase 2, many hundred people. Phase 3, few thousand people. Phase 4, many thousand people. Now, what kind of trials do you do? In PSM, you must have studied open-ended trials and closed-ended trials. Open-ended trials means the patient knows that he is taking the drug. Closed-ended trial means the patient doesn't know that he is taking the drug. Okay. Now, so phase 1 and phase 4 are open. Phase 2 and 3 are closed. You can see here the table is open to this side, this table is open to this side, these two are closed, so you can remember it that way. Phase 1 is also known as human pharmacology and toxicology study, because you are studying about the toxicity and pharmacokinetics and dynamics. That's all. Now, phase 2 is known as therapeutic exploratory trial, because you are exploring the efficacy. Phase 3 is known as therapeutic confirmatory trial. Now, what about phase 4? It is known as post-marketing surveillance. So, that's all about the general pharmacology. As I have told, see, some basics had to be explained in the ANS and general pharmacology. I have done my part. I finished explaining the concepts to you. From now on, everything that is left out as systemic pharmacology, you must have studied and covered all of this in so many subjects. So, we are going to go superficially without going into the concepts here. Okay. Now we have finished with the general pharmacology. Now we are going to start with the systemic pharma. Since these are easier chapters, we are going to breeze through each of them, and we are going to do the MCQs of all these 4 chapters after the respiratory system. Okay. So, starting with autocoids. Autocoids means they act locally. Local. It is acting locally. There are amines, peptides, lipids in all of these. In the autocoids, first we'll start with amines. These are histamine and serotonin. Now, histamine related drugs. Histamine, when it activates the H1 receptor, it will cause allergy. So, to treat this allergy, we will give H1 receptor blockers. H1 receptor is also responsible for wakefulness in the body. So, if you block this H1 receptor, it will cause sedation, isn't it? So, antihistaminic drugs will cause sedation. That is why when you take a cetirizine tablet, you feel sleepy, isn't it? So, we'll see. First, we have made antihistaminics. They used to cross the blood-brain barrier and it will cause sedation. These are first generation. So, we try to make Other class of drugs which are not crossing the blood-brain barrier, so it is not causing the sedation, these are known as second generation antihistaminics. First we'll do antihistaminics that are in first generation. Even though these are antihistaminics, it has maximum anti-muscarinic effect. So these are used in conditions where anti-muscarinic drugs are required. Example, motion sickness, what is the drug of choice? Scopolamine. Example, drug-induced Parkinsonism, what is the drug of choice? Benzexol. Let us suppose if scopolamine and benzexol are not available in this condition, what can you give? You can give first generation antihistaminics like promethazine, diphenhydramine and dimenhydrinate. Promethazine, diphenhydramine and dimenhydrinate. These can be given in motion sickness and drug-induced Parkinsonism. Why? Because these have the maximum anti-muscarinic effect. Maximum anti-muscarinic effect. Did you understand this much? So these are used in drug-induced Parkinsonism and motion sickness. Now, can you give this in our patients? Can you give this in people who requires lot of attention? Think about it. Since they are crossing the blood-brain barrier, they will cause sedation, so you cannot give it. So these are contraindicated in pilots, drivers, especially heavy vehicle drivers like lorry drivers and students. Did you understand? So first generation antihistaminics we are not using in allergies, we are only using it in motion sickness and drug-induced Parkinsonism. Coming to the second generation, these don't cross the blood-brain barrier, so it is not causing the sedation or lesser sedation. That is why these are preferred antihistaminics. Therefore, these are drug of choice in urticaria. Okay. Examples. Cetirizine. See, cetirizine comes from a derivative that is known as, cetirizine is a derivative of hydroxyzine. It is made from hydroxyzine. Hydroxyzine is a first generation antihistaminic. That is the reason why cetirizine still has sedation even though it is second generation antihistaminic. That is the reason why we have made levocetirizine. Levocetirizine is less sedative than cetirizine. Now, what is the least sedative drug of all? It is fexofenadine. I told you, second generation antihistaminics are causing lesser sedation. But in all of the second generation, which is having the least sedation potential is fexofenadine. Now, other drugs are rupatadine, olapatadine, alcapride. See, olapatadine is actually used in something known as VKC, vernal keratoconjunctivitis. Vernal keratoconjunctivitis. VKC. This is allergic conjunctivitis. Did you understand? It is also known as spring catarrh. Now, in the second generation, estimazole and terfenadine are blocked because they can cause QT prolongation. That's all about the antihistaminics. And in antihistaminics, there is a drug called doxylamine. Doxylamine plus vitamin B6 is the drug of choice for morning sickness. Doxylamine plus vitamin B6 is the drug of choice for morning sickness. Now, we have finished antihistaminics. We will start with the serotonin related drugs. Now, why are these serotonin related drugs important? Let us try to see in the chapter called migraine. So, we will talk about migraine first. See, what or how do you have migraine? There are many theories for it. I will talk about one theory here because the theories for migraine are not proven. We have 2 or 3. Yes. So, I will talk about one theory. One theory says whenever CGRP is released, this CGRP will act on the CGRP receptors of blood vessels and it will cause vasodilation. Because of vasodilation, it will compress the meninges and it will cause the headache that you see in migraine. Okay. When it acts on the CGRP receptors present on neurons, it causes neuronal inflammation. So this is what is happening. Basically, when CGRP is released, it will cause migraine. Okay. Now, fortunately, we have autoreceptors here. If you remember, autoreceptors means brakes. They are present in presynaptic or postsynaptic. I talked about alpha 2. Alpha 2, presynaptic or postsynaptic? Obviously presynaptic. On presynaptic, we have serotonin receptors like 5-HT1B and D. These are autoreceptors. So, if I activate these receptors, it will block the release of CGRP. It will cause vasoconstriction. It will decrease neural inflammation. So, that is the reason why these are used in migraine. Yes. So, what are the first class of drugs? In the acute attack of migraine, we give 5-HT1B and D agonists. Since these are autoreceptors, they will decrease the release of CGRP. What are the drug names? These are triptans. Rizatriptan, sumatriptan, amitriptan, frovatriptan. Yes, all these triptans. Now, there are some other ergot derivatives. They also work the same way. Ergot derivatives. These are ergotamine. Ergotamine. Now, problem with these drugs. Both of them work the same way, but the problem or side effects. See, 5-HT1BD. If you remember, I told you wherever BD receptors are present, I told you they are present on blood vessels. So, 5-HT1B and D receptors are also present on blood vessels. When these are activated, it will cause vasoconstriction. So, it will cause vasoconstriction in the brain, then it is helpful in migraine. But if it is causing vasoconstriction in other parts of the body, is it helpful to us? No, actually it is not. Why? Because if it is causing vasoconstriction in the peripheries, it will increase the blood pressure. And if it is causing vasoconstriction in the heart, it might increase the risk of ischemic heart disease. So these are the side effects. It can cause hypertension or it can increase the risk of ischemic heart disease. So ergots and triptans can do this. So if you give ergots and these triptans together, there might be severe vasoconstriction and formation of gangrene on the peripheries. This is what is known as ergotism. Can you see here? This is what is ergotism. That is why triptans and ergots are never given together. They are avoided. Now, if you understood this much, this is about 5-HT1B and D receptors. These are autoreceptors and they are also present on the blood vessels. Now, there is one more autoreceptor, that is a new one, that is 5-HT1F. So, if we activate this, same thing will happen. This is a new drug that has been discovered recently, invented recently. This is lasmiditan. Okay. Now, CGRP acts on CGRP receptors, so we can also directly block the CGRP receptors. These are known as CGRP receptor antagonists. These are rimegepant and atogepant. Now, in the acute attack, these are all the drugs you can use, and you can also use NSAIDs like paracetamol and ketorolac if it is a severe attack. What can you do? You can use opioids like butorphanol. Okay. So, mild attack you can use NSAIDs. If it is severe, you can use opioids. Simple. So, this is about the acute attack of migraine. Now, let us suppose a patient has come to you with a mild headache. What would you do? You should start with NSAIDs, preferably paracetamol. If not, then you go to ketorolac. If a patient has moderate to severe headache, you preferably give what? Triptans or ergots, but not together. You can give NSAIDs plus caffeine. It will work well. In pregnancy, what can you do? Obviously, the best drug would be paracetamol. You give paracetamol. If paracetamol is not working, then you can give sumatriptan. Other triptans are not safe in pregnancy, only sumatriptan can be given. But I told never combine triptans and ergots together. Now, drug of choice for migraine prophylaxis, we have talked about this in the first chapter. It is propranolol. It is propranolol. So we have finished with the amines. Now we'll see the lipid autocoids. In this, we have to study about the prostaglandins and the drugs inhibiting these prostaglandins. Drugs inhibiting these prostaglandins are NSAIDs. How? I'll tell you. See, in the cell membrane, we have phospholipids. Yes, I told you, every cell membrane is made up of phospholipid bilayer with proteins in it. Now, this phospholipid is broken down by phospholipase A2 and this forms arachidonic acid. On this arachidonic acid, COX enzymes and LOX enzymes will act. When COX enzymes act, it will release this prostaglandins. So, if you block this COX enzymes, this prostaglandins will be reduced. These are known as NSAIDs. NSAIDs. Why are we blocking this? Because prostaglandins can cause inflammation. Now, if you block this phospholipase A2, these are known as steroids. So, steroids will block the entire pathway. So, the best inflammatory drug is steroids. Next is NSAIDs. NSAIDs only block COX. That is why these are known as non-steroidal anti-inflammatory drugs. Steroids are steroidal anti-inflammatory drugs. NSAIDs are non-steroidal anti-inflammatory drugs. That's all. So, first we'll see about prostaglandins and what they are doing in the body. Now, prostaglandins are several types. First, we will see there is prostaglandin E. So, we try to make prostaglandin analogs like prostaglandin E1 analogs and E2 analogs. Prostaglandin E1, there is misoprostol. Misoprostol is actually used in the first trimester abortion. This is the drug of choice in the first trimester abortion because it contracts the uterus. Misoprostol is also specific drug for NSAID-induced peptic ulcer. NSAID-induced peptic ulcer. Why? I told you, prostaglandins are gastroprotective. If you give NSAIDs, they will block this and it will cause the peptic ulcer. So, how can you treat it? By increasing these prostaglandins. That is why we are giving the misoprostol. Why am I saying specific drug but not the drug of choice? Because drug of choice for any peptic ulcer disease is proton pump inhibitors. Good. Now, alprostadil, it is given in the name DIL, so it must act somewhere on the heart. So, it is helpful for keeping the patency of PDA, patent ductus arteriosus. Patent ductus arteriosus usually closes after the childbirth. Yes, to keep it open, we can use alprostadil. Now, next is PGE2 analog. This is dinoprostol. This is the drug of choice for cervical ripening. So, E is finished. Next is F. Prostaglandin F2 alpha analog. In this, the most important one is latanoprost. Latanoprost is the drug of choice in open angle glaucoma. What is the drug of choice in closed angle glaucoma? It is pilocarpine. What about open angle glaucoma? It is latanoprost. Latanoprost is prostaglandin F2 alpha analog. Now, dinoprost and carboprost can be used in abortions. Carboprost can be used in PPH. Now, coming to PGI2 analogs, this will study when we are studying the pulmonary artery hypertension chapter. Yes, these drugs can be used in pulmonary artery hypertension because they will cause vasodilation in the pulmonary arteries. Okay, so these are the prostaglandin analogs. The most important one is misoprostol, alprostadil, and the next one I wanted to remember is latanoprost. Now, what are the side effects of latanoprost? They will ask you. You can remember PGF. P means pigmentation of iris. This is also known as heterochromia iridis. G is growth of eyelashes. It will increase the growth of eyelashes and it will cause fluid in the eye. So it will cause macular edema. These are the side effects of latanoprost commonly asked. Okay. Now, in the abortion, I told you, in the first trimester, what do you give? In the first trimester, you give mifepristone plus misoprostol. First, you give the tablet of mifepristone. Why? Mifepristone is it is given in the name PRIS. It is a progesterone receptor antagonist. So, it will cause detachment of the embryo, and you have to cause contraction of the uterus by giving misoprostol. Now, second trimester, what can you use for the abortion? You can use dinoprost, carboprost. All of these are used in the second trimester, but according to the gynecology textbook, they say here also misoprostol is used. So that's all about the prostaglandins. Now coming to the NSAIDs. NSAIDs are COX inhibitors. So they are decreasing the production of prostaglandins. So they will decrease the inflammation. They will decrease the fever. So that is why whenever you have fever, you take paracetamol as an NSAID. Okay. So first let us see paracetamol. What is the drug of choice for paracetamol toxicity? If you take a lot of paracetamol, it will damage your liver. Now, when the liver is damaged, what or how it is damaged? It actually decreases the glutathione level, so it will cause free radical injury. Now, to prevent this, you can give N-acetylcysteine. N-acetylcysteine. I already told you what is the side effect of paracetamol poisoning. It is hepatotoxicity. Yes, how can you predict this hepatotoxicity? By something known as Rumac-Mathieu normogram. Rumac-Mathieu normogram. Yes. Now coming to the aspirin. Aspirin is an antiplatelet drug. Yes, true. It is an antiplatelet drug. It is also an anti-inflammatory drug as well. But what is most important to us are the side effects. Aspirin can cause bleeding. Aspirin can cause race syndrome. It can cause Samter's triad, and it can also cause hyperuricemia. Yes. Now, what is race syndrome? Let us suppose a child is recovering from viral illness, viral flu or something, and if you give aspirin in this patient, it will cause hepatic encephalopathy. Hepatic encephalopathy, this is what is known as race syndrome. This is known as race syndrome. Okay. Now, what is the drug of choice for aspirin toxicity? I told you, aspirin is a acidic drug. So you do what? Forced alkaline diuresis. Forced alkaline diuresis. If no response, obviously you will do hemodialysis. This is what I told you. So these are the two important NSAIDs I want you to know. And these NSAIDs will block both COX-1 and COX-2 inhibitors. So because of this, it will cause a side effect. It will cause a side effect, that is peptic ulcer disease. Because COX-1 is protective. So we have made a drug that is known as selective COX-2 inhibitors. So these are also known as COXIBs. They will not block COX-1. That is the reason why they don't cause peptic ulcer disease, but they cause cardiotoxicity. So what are the drugs? Etoricoxib, celecoxib, parecoxib. These are selective COX-2 inhibitors. Okay, but they are causing cardiotoxicity. That is why reficoxib and valdecoxib are banned, because they have caused cardiotoxicity. Did you understand? So the other ones are non-selective COX inhibitors. These selective COX-2 inhibitors can cause cardiotoxicity. Now, if you want to close the patent ductus arteriosus, which NSAID can be used? Because I told you, if prostaglandin E is present, it will keep the ductus arteriosus patent. So how can you decrease this prostaglandin? By giving NSAIDs. So NSAIDs can cause closure of patent ductus arteriosus, isn't it? Which NSAIDs? There are two. You can give indomethacin or ibuprofen. The drug of choice in India is ibuprofen. In India is ibuprofen. Okay. Now, what are the side effects of these NSAIDs? It can cause hypersensitivity reactions, peptic ulcer disease, and nephrotoxicity. This much you know. Everybody tells you painkillers will damage your kidneys. Yes, yes. Now, NSAIDs should not be used together. used together with ACE inhibitors because of hyperkalemia. This has been asked in the recent FMGE exam. Why NSAIDs will decrease prostaglandin? Because prostaglandins usually cause increased GFR. If there is decreased prostaglandin, there is decreased GFR. So filtration is reduced. So sodium and potassium stay inside the body. If potassium is staying inside the body, it will cause hyperkalemia. ACE inhibitors will also cause hyperkalemia. That is why both of them cannot be used. If you use both of them, it might cause hyperkalemia. They might cause arrhythmias. The patient might die. That's all about the NSAIDs. Now, coming to the easier chapter, that is about the gout. Gout, in the acute attack, what is the drug of choice? First, let us see what is gout. Why is this gout happening? This happens whenever there is increased uric acid. If the increased uric acid is in the blood, we call it hyperuricemia. Now, this uric acid will go and deposit in joints and other areas. If it deposits in the joint and causes inflammation, this is what is known as acute gout or acute gouty arthritis. Why? Because in the joint it is causing inflammation, redness, pain, swelling, all of this. How do you treat all of this? I told you, how do you treat inflammation? By giving NSAIDs. So the drug of choice for acute attack of gout is indomethacin. If indomethacin is not working, if there is no response, you can give colchicine. If colchicine is not giving any response, then what can you do? You can give intra-articular steroids. Why? Steroids are the best anti-inflammatory drugs. That's all. This is about the acute attack. Now, why is this acute attack happening? Because of hyperuricemia. So, in chronic attack, what is your aim? To decrease the uric acid. How is uric acid formed, you ask? How is it formed? Think. Let us suppose you're eating too much of meat or whatever it is. If the cells are being broken down, cells are made up of purines and pyrimidines, isn't it? When these purines and pyrimidines are broken down, they are forming xanthines. From these xanthines, you have uric acid. Now, which enzyme is converting these xanthines into uric acid? It is xanthine oxidase. So, if you block this, will uric acid be formed? No. So, xanthine oxidase inhibitors are the drug of choice for chronic attack of gout. That is what is allopurinol. If allopurinol is not working, you will give febuxostat. So, which drug can be used for prevention of uric acid formation? That is allopurinol and febuxostat. Drug of choice for chronic gout is allopurinol. Now, let us suppose there is already lot of uric acid in the body. How can you treat this? Lot of uric acid. Will you give allopurinol? If you give allopurinol, it will stop the formation of new uric acid. But what about the present uric acid that is already in the body? What will you do for this? Think. There is a condition that is known as a tumor lysis syndrome. What do you mean by tumor lysis syndrome? Tumor means overgrowth of cells. There are a lot of cells. In tumor. When you give chemotherapy, all these cells are dying. If all these cells are dying, purines and pyrimidines in these cells will come out. They will be converted into uric acid. There is a lot of uric acid now. Now you cannot use allopurinol to decrease this uric acid. What will you do? See, in the birds, uric acid is converted into allantoin by uric acid oxidase enzyme. This is also known as uricase. So what did we do? We tried to make a uric acid analog. That is what is uric acid oxidase analog. That is what is known as recombinant uricase. The answer is pegloticase. That is the reason why we use pegloticase in tumor lysis syndrome. Did you understand this much? Now, there are some other uricosuric agents. That means it will increase the excretion of uric acid from the kidney. Examples are probenecid, sulfenpyrazone, benzbromaron, lesirinide. But these are not commonly used because whenever there is uric acid going into the urine, it will cause stones. It will cause stones. This is about the gout. I want you to remember acute attack. Indomethacin, if it cannot be used, colchicine. Colchicine will cause a peculiar side effect, that is, it will cause intractable diarrhea. Lot of diarrhea, severe diarrhea. That's all. For chronic attack, allopurinol, if it is not available, febuxostat. In tumor lysis syndrome, you use pegloticase, but to prevent the formation of uric acid, it is allopurinol. Okay. Now, the last one, this you will study in the medicine, rheumatoid arthritis. What are you going to study? This is a what? It is an autoimmune inflammatory polyarthritis. This will cause deformities if it is not treated properly. Now, how can you treat them? Obviously, whenever there is an acute attack, you try to treat it with the NSAIDs. But the problem here is inflammation. How can you stop the inflammation? Obviously, by steroids you give. Okay. Now, can you actually treat this disease? Can you actually decrease or stop the disease progression? See, you cannot stop the disease progression, but you can decrease the disease progression. This is done by something known as DMARDs. These are disease modifying anti-rheumatic drugs. That means the disease process will continue. We can only slow it down with the help of DMARDs, disease modifying anti-rheumatic drugs. But these DMARDs will take 3 months to show effect. Till those 3 months, we use corticosteroids. That is why we call this bridge therapy with corticosteroids. So, we are giving DMARDs along with corticosteroids for the first 3 months. Yes. What are these DMARDs? These are the 4 things that we generally use. We either use methotrexate, hydroxychloroquine, sulfasalazine, or leflunomide. Methotrexate is also drug of choice in choriocarcinoma. Methotrexate, the most common side effect, it will cause hepatotoxicity. Now, coming to hydroxychloroquine, it comes from a drug that is known as chloroquine. Chloroquine has a very high volume of distribution. In fact, this is the highest. Its volume of distribution is more than 15,000 liters. So, it goes into all the tissues and it will cause side effects in all the tissues. In the eyes itself, it will cause vortex keratopathy in the cornea. And the most important one I want you to remember is it will cause a bull's-eye maculopathy. Bull's-eye maculopathy, vortex keratopathy, yes, posterior subscapular cataract, many things it will cause. But this is the safest DMARD in pregnancy. Next, sulfasalazine is contraindicated in G6PD deficiency. Leflunomide side effect is hepatotoxicity and megaloblastic anemia. You study it in a lot of detail in internal medicine, but I am just telling you the drug names. Okay. Coming to the biologics, what we usually do, this rheumatoid arthritis is happening because of some agents like TNF alpha. So, we are giving anti-TNF alpha like infliximab, adalimumab and golimumab. How do you do the treatment? You give DMARD along with biologics. Yes, if biologics is not working, you give JAK-STAT inhibitors like tofacitinib and baricitinib. NIBs are JAK-STAT inhibitors. Now, what is the side effect of anti-TNF alpha? This is reactivation of latent TB and it increases the risk of hepatitis B and C. So, that's all. This is the short version of autocoids. Usually, these are the most important things that are asked from the autocoids.